Assalamu alaikum everyone. I'm Abdulrahman Abu Zubaydah. Today, inshallah, we'll be discussing the brainstem and its lesion. What is the brainstem? Anyone? A connection, that's a very important word. Any other thoughts? What is the brainstem?
It also basically acts like basically where the ascending and descending usually meet.
So it's a connection, it's a pathway. Okay, it's consisting of three things. What are they? Bones, medulla, and midbrain. Starting from higher top, what's the highest? Midbrain, bones, medulla. So it's a connection for the ascending and descending tracts to and from the brain, right? And the second thing, it originates or it's home to exactly nuclei of what? Cranial nerves, except olfactory and optic nerve. Before I start talking about the brainstem and its contents and so on and so forth, I want to revise the functions of the cranial nerves, okay? And even before I do that, there is something else that's present in the Walaikum Assalam. Something else that's present. Thank you. Oh yeah, sorry. Which is nuclei, other than the cranial nerves. What are they? What type of nuclei?
Corticospinal nuclei.
These are not nuclei. These are tracts. Nucleus ambiguous, it goes to the cranial nerves, but what I'm trying to deliver is nuclei for the cardiovascular system, for the respiratory system, even for the consciousness, and even for vomiting, like nucleus tractus solitaris. So, if someone has a brainstem lesion, he may lose consciousness. Someone else who has a brainstem lesion, he may lose the function of the heart. His heart may stop. And this is what happens clinically when we say there is brain death. Brain death, right? One of the biggest criteria for brain death, we have to test for all the brainstem reflexes. Okay? So quickly. Just quickly, if we want to revise the brain or the cranial nerve functions, can someone start with the first one? What's its name and its function?
Olfactory.
Olfactory.
Smell sensory.
So whenever we speak about the cranial nerve functions, there are four types of functions that the cranial nerves can have. The first one is general sensory, special sensory, motor, and parasympathetic or autonomics. These four functions of cranial nerve, of any cranial nerve. Some have all four, some has only one, some has a mix of two, so on and so forth. So the olfactory nerve, its function, special sensory, which is smell. Then optic nerve
is also special sensory.
Okay, for vision.
Sight.
Any other function of the optic nerve?
No.
Then comes
The
reflex. We'll come to the reflexes.
Oculomotor.
Oculomotor.
Motor.
So motor for what?
Eyes, muscles of the eyes, except superior.
Except two. We will come to them later. So that's the general motor. What else?
And parasympathetic.
Parasympathetic in terms of
circulatory.
not parasitic gland.
Eye
Constricting the pupil.
Yes. So it causes constriction of the pupil. It causes meiosis. So let's say, for example, I cut the oculomotor. Is there gonna be meiosis?
Neither is
So what will happen? I lost the function, اللي هي meiosis. So what will happen? Dilation. Because whenever we speak about meiosis and mydriasis, we have two counteracting forces. One that's causing meiosis constantly, and the other that's causing mydriasis constantly. What are they? We said the oculomotor, اللي هو parasympathetic, it causes meiosis constantly, and the second one is So what's opposite of parasympathetic?
Sympathetic.
Sympathetic, that causes
Mind
mind races or dilation. So if I lose the parasympathetic, what will be?
Sympathetic increases.
Sympathetic will not increase. It will just be
Opposed.
uninhibited or unopposed, right? The same thing. If I lose the sympathetic, there will be unopposed parasympathetic, which will lead to constriction, which we see it in Horner syndrome. Everything makes sense so far? So this is the second function of the oculomotor, اللي هي autonomics. What else?
The eyelid.
What about it?
There's a muscle that
Levator
elevates.
Yes, levator,
elevates the eye.
levator,
Palpebral.
palpebral,
So,
superioris. Okay, so it keeps the eye open. If I lose the oculomotor, what will happen? Ptosis, right? So the eye will be closed. Not closed fully, but يعني closed.
Yeah, what's for later, of course, but I just wanted to ask now. There's a difference between partial ptosis and complete ptosis.
Right.
Can we get back to that?
Sure,
whenever
we'll get
you
back
like?
to it when we speak about the Horner syndrome and the oculomotor lesions.
Okay.
Okay?
Thank you.
So this is the oculomotor. Any other functions of the oculomotor?
it supplies one gland.
What gland? No. No, that's it about the oculomotor. Okay? Now, then, the fourth nerve, trochlear, the function.
Motor innervation of the superior oblique.
So how does it function superior oblique? Let's say this is my eye. This is my eye. Where? This is my left eye. Where is superior oblique attaching?
Lateral.
So I'll give you some examples. Is it attaching like this, or like this way, or that way?
Do you need the mic?
Yeah. I think my voice is clear, صح? Do we need a mic?
The only reason is not because it's being recorded. So if you use a mic, it'll be clear.
Okay. I'll try.
Thank you so much.
Yes. So superior oblique, it originates from the midline, it goes, crosses all the way laterally, and attaches laterally, right? So whenever it contracts, what will happen? We will do some intorsion of the eye will flip medially, okay? The second thing, the eye will go down, and the last thing, it will go.
So like it will go.
I'll show you a video, so it's better showing the function of trochlear nerve. Look at the attachment of the superior oblique. So whenever it contracts, it will cause medial rotation of the eye, intorsion. In the same time, it will depress it and cause it to go a bit lateral. So I'll just try to show you. Look at it. You see? So three functions of superior oblique. That's about it. Any other functions of the trochlear nerve? No, that's it. So then comes which nerve? Trigeminal. Give me the four functions.
It supplies the muscle of mastication, which is the.
So this is motor, muscles of mastication. If someone doesn't have the trigeminal,
He wants to be able to.
there will be. Okay, it is jaw weakness, that's right. However, why is our jaw standing in the midline?
This is going to be open.
I'll come to that, but more. Remember how I spoke about the sympathetic and parasympathetic? How we always have something opposing the other? In this case, for the trigeminal, what we have is the muscles of mastication. One side keeps it or pushes the jaw to the other side, and the right side pushes the jaw to the left side. You know, they're opposing each other. If I have them both intact, the jaw will stay in the midline. If I lose one, I lost the left trigeminal.
It's going to be
Deviation to which side? To the opposite side. Does it make sense?
Yes.
Because each one is pulling to its side. I'll come to it later. I'm just trying to give you an idea. Every time we have something bilateral, there has to be a fine-tuning of forces, one opposing the other. Sympathetic, parasympathetic. Jaw muscles, tongue muscles, so on and so forth. We'll come to them later. Then, after the muscles of mastication, so this is one function.
We have the
Sensory,
Facial sensation.
facial sensation through the
Ophthalmic.
ophthalmic, maxillary, mandibular. Right, what else? This is special or general? General sensation. Then,
we also have supplying of the anterior 2/3 of the tongue.
in terms of which sensation?
Specific.
General sensation. Trigeminal is only general sensation. The special sensation of the tongue comes, I'll come to them later because we mentioned them by the cranial nerves.
So basically, if it's hot or cold, that's basically the sensation.
Yes, by the anterior 2/3, here it comes from the trigeminal. This is the trigeminal. Then comes the sixth cranial nerve, abducens. What does it do? Lateral rectus. The lateral rectus function,
Move the eye.
it will abduct the eye. طيب, any other functions of the abducens?
It's motor. So
Purely motor. Then comes the
facial.
facial, cranial nerve 7. Again, apply the 4 functions.
Movement of the.
So motor, facial expressions,
Sensation also can be.
special sensation when it comes to anterior 2/3 of the tongue. So that
basically
stays
the taste is from the facial.
anterior 2/3
Oh.
only. Okay, then
The stimulation of the sublingual and submandibular, or no?
yes, you're right. So we have the salivary glands, mandibular and sublingual glands, and another thing, lacrimation. All of these are autonomics. Lacrimation, salivary glands and lacrimation are all autonomics.
Autonomous.
Do we have any sensation?
Other than that,
Where?
I
We
think
don't.
that's basically it.
We don't. But one important thing about the facial nerve, it goes and it supplies one specific muscle in the ear. What is it called? Stapedius. The function of stapedius, it lowers the voices. It lowers the voices. This place is so loud, stapedius will lower the voice for you. If you don't have, if anyone doesn't have a functioning stapedius, the voice will be so high. So what will happen to the patient? Not deafness. He will start. He will stay in his home. He will never go out to social gatherings. He will never go to work because every time he goes out, he'll tell you it's so loud. We call it hyper acusis. Okay. So the clinical sign is the patient being isolated. He will isolate himself. When you start asking him more questions, he will tell you it's only because I hear everything so loud. Then after the facial nerve, we get vestibulocochlear. The functions again. Hearing and balance. Do we have anything else for the vestibulocochlear? Nothing. Then glossopharyngeal. Posterior 1/3 of the tongue in terms of taste.
And also stimulation of parotid.
And sensation as well. Both. The glossopharyngeal supplies the tongue for special and general sensation. Both
And
together.
the parotid gland.
And the autonomics when it comes to the parotid gland. And one thing,
Chemoreceptors and baroreceptors.
that's autonomics again. But one thing in terms of motor, there is one muscle that the glossopharyngeal supplies. Yes? Stylopharyngeus, right? Yes, stylopharyngeus is supplied by the glossopharyngeal.
And the elevations of the pharyngeal system.
Because of stylopharyngeus.
Yeah.
So this is the glossopharyngeal. Then comes vagus. Apply the 4 functions.
Parasympathetic.
Thought about every single one. Start every time, whenever you think about these functions, start by sensory, special sensory, motor, and lastly autonomic. So apply it now. Sensory.
Posterior, 1/3 of the tongue.
Posterior 1/3 of the tongue. That's general sensation. What else?
Wait, we're talking about vagus?
Yes. Not posterior 1/3. Sorry, not posterior 1/3. It's the base of the tongue, the base of the tongue. Thank you for reminding me. Yes, when we speak about the vagus, it's the base of the tongue, not the posterior 1/3. So that's general sensation. What else? In terms of special sensation,
Taste.
taste for what part?
Supra-
Again, the base of the tongue. Here, sometimes they say it's the supraglottic area or whatever. We call it the base of the tongue. So this is special sensation. Then comes motor.
Swallowing.
It helps in swallowing, definitely. And you take it, I don't know if you took it. Do you ever hear about recurrent laryngeal?
Yes.
Where does it come from?
From the vagus.
From the vagus, right?
Hoarseness.
So-
So if you lose the vagus, the patient will have hoarseness, dysphagia because they cannot swallow.
And also the baroreceptors and the chemoreceptors.
And lastly, autonomics. When it comes to the baroreceptors, what else about the autonomics in the vagus? GI. Okay, but we don't care about it much in terms of the GI and the baroreceptors. I'll come to it later. So this is the vagus. Then comes the which cranial nerve? Accessory. 11. What's the function? Apply the 4 rules.
Motor supplying of the trapezius.
Start by the general sensation. Do we have any general sensation?
It's motor only.
So no general sensation. Is there any special sensation? No special sensation. Is there any motor?
Yes.
2. Sternocleidomastoid and
Trapezius.
trapezius. Someone loses the sternocleidomastoid, he cannot look toward it, so his head will be deviated to the other side, right?
Yes.
Because again, what do we have? Opposing factors, right? Right sternocleidomastoid, left sternocleidomastoid. Does it make sense?
Yes.
I have a question.
Yes.
Why isn't the accessory in the midline? Yani, killing purely motor nerves are in the midline except accessory. Like, what about
I actually don't have an answer to that. However, what you're saying is not completely true, and we will find out why in a bit, inshallah. So that's one thing. If you're saying the purely motor, cranial nerves. Okay, yeah, you're right. Actually, you're right. Okay, but I'm speaking about something else, not just only the cranial nerves. So this is the accessory, and the last one is the hypoglossal. The function. Apply the 4 rules. Sensation, general sensation. Nothing. Special sensation. Nothing. Motor. Tongue movements or the muscles of the tongue. And lastly, the autonomics. Nothing. Everything is clear? This is just a quick picture from first aid showing you everything that we just discussed. And so now when we talk about the reflexes, every time we talk about reflexes, we have to know that the first part of a reflex is actually feeling or sensing what I have in hand. You know, I cannot feel something that's not in my hand, right? And I cannot act accordingly because I have nothing in my hand. So the same thing happens to cranial nerve reflexes. The way I memorize them is we have 3 reflexes in the eye and 3 reflexes in the mouth. In the eye, the first one here, most obvious, if I shine a light in your eyes, what will happen to your pupils? Constrict. What did we say? What cranial nerve senses the light for vision? Senses the light for vision. What gives us vision? Optic. So
constriction is going to be the second cranial.
wait, the sensing part, the one that brings the information to the brain, which one? Optic nerve, the one that actually senses the light. صح? So this is the one that will bring all the information to the brain, and then what will act? Oculomotor, in a way that it will Constrict, because what muscle or what cranial nerve supplies the pupils in terms of meiosis? Oculomotor. Does it make sense? Now, another one in the eyes. If someone brings a cotton and touches the white part of your eye, okay, what will happen? You will close your eye. So, the cotton touch, this fine touch with the cotton, what do we call it? Is it special sensation, general sensation? What is it? General sensation. And what did we say? What nerve supplies the general sensation of the face? Trigeminal. Which part specifically of the trigeminal? Because it's up? Ophthalmic. So the ophthalmic will sense this touch. It will register it in the brain. We call that afferent with an A. So it brings the information to the brain. And what will act to close the eye? Which one? Facial, right? Because which muscle or which cranial nerve supplies all the muscles of the face? The seventh, including orbicularis oris, or no, orbicularis oculi, correct. Orbicularis oris is for the mouth. Does it make sense so far? The last one is the lacrimation reflex. We said that, let's say for example, the eye, it's dry, right? Which cranial nerve has the general sensation that will tell us that this eye is dry? Trigeminal. So which one is the afferent or the sensing part? The ophthalmic, اللي هو part of the trigeminal. It registered the information in the brain, and lastly it went back to the eye. Which part of the eye? Facial nerve. To which part exactly? To the lacrimal glands. Does it make sense? And the lacrimal glands with the facial nerve, it will contract and release some tears. Then comes the, now when we speak about the accommodation, I don't consider it, let me just start pointing. Okay, so you see the accommodation? I don't consider it a separate reflex about from the pupillary. Why? Because the accommodation reflex, one component of the accommodation reflex is pupillary constriction, right? What's other parts of the accommodation reflex? Three things. So let's say, what's accommodation? Let's say I'm bringing my finger to one patient and I'm putting it close to their eye. What will happen to his eye? I'm telling him, follow my finger. Okay? Normally, try it on yourself. Everyone, put your finger ahead of you. Now look, focus on your finger and bring it close to your eye. What happened to your eye when you brought it in? The eyes converged, right? They came in together. So this is one component of accommodation. The second is, I spoke about it, is the pupillary reflex. So what will happen? Meiosis. And the last one? What will happen? The lens will react, because we're differentiating between the pupil and the lens. The lens will contract, it will become more flat, more convex. When you compare it to another thing is, if you're seeing something very far, your eye wants to focus on that far thing. What will happen to the lens? The lens will relax, they will become more concave, more circular. Does it make sense so far? So I don't differentiate between the accommodation and the pupillary reflex. And the same thing you can apply to all other reflexes. Just think about everything we discussed when we talk about what senses first, the general sensation, followed by what will react accordingly. Now, if someone is putting their fingers on the back of their throats, where does the sensation come from? How can I sense that something is in the back of my throat? Glossopharyngeal, because it's general sensation. And what will act? The vagus, and sometimes even some like overlap with the glossopharyngeal, but mainly the vagus. So that's for the gag reflex. Just a quick revision. Again, I know I'm revising a lot, but it's really needed. So let's see, what is that? Someone is feeling some pain. How's the pain felt? we have nerve endings present at my finger. For example, someone burnt my finger. We have nerve endings at my finger, feeling this burn, okay? These nerve endings will go, this is the dorsal root ganglion, and they will go into the posterior side of the vertebral column. What will happen?
Synapses.
They will synapse with the
Secondary neurons.
secondary neurons, اللي هم, what do we call them? In the dorsal part of the vertebral column, lower motor neuron or first order, they will synapse with the secondary order. This is the first order neuron, the one that sensed actually the burn. They will synapse here, and what will they do?
Cross to the other side.
They will cross at the same level. They will cross to the, because this is the left hand, they will cross to the right side and they will start going up. And this is what we call the spinothalamic tract. It senses two things, pain and temperature, and it decussates, it crosses the midline at the same level or one level above.
Yes. This is the
Let's say the same level for the sake of making things easy. So this goes as the spinothalamic tract. It's ascending, it goes up. On the other hand here, we have someone who is feeling vibration. I brought a tuning fork and I put the vibration on his joint. What will happen? The first order neurons are sensing this. They go to the spinal cord and they will go to the dorsal column. They will synapse and they will go to the dorsal column on the same side. This is the right hand, this is the right side. They will go on the same side and they will go up until they reach the medulla. Let's say this is the medulla. They will decussate or cross the midline, and then it will go higher up as the medial lemniscus. Does it make sense?
Yes.
So far makes sense? This is what we call the dorsal column. It senses three things. Vibration,
touch discrimination,
fine touch, and proprioception.
Is this the one that we took, just the spinothalamic or the?
No, the spinothalamic is pain and temperature.
Ah.
The dorsal column is vibration, proprioception, fine touch, or two-point discrimination. And the last one, the one that's descending, let's say I want to move my arm. The stimulus comes from the brain, from the cortex. Which part of the cortex? Precentral gyrus, the motor area. It will go in and descend as corticospinal tract. It reached the medulla. What it will do? Decussate, cross the midline, and it will go down. And then this is the level, for example, my right arm, and I will be able to do the movement. I will not discuss the first order or second order neurons. If you want, I can do it after the lecture. But for now, I just want you to know, where is the decussation of the spinothalamic? Same level. So if I cut something in here, which side will be affected when the spinothalamic? Contralateral. If I cut something at the same level? At the same level. At the same level, so it's at the same side.
This is the spine?
This is the spinothalamic.
It crosses immediately.
Right, so if I cut it at the crossing, so at the same side will be affected.
Okay, got it.
Right? So this is the spinothalamic. Let's apply the same rule for the medial lemniscus or the dorsal column. If I cut something above the decussation, which side will lose vibration? The other side. If I do the same thing with the corticospinal above the decussation, aka where above ish, where is the decussation? Above the medulla. It's the lower part of the medulla. So anything medulla and above, it will cause contralateral signs. If it's the corticospinal, it's upper motor neurons for the upper motor neurons, and if it's the dorsal column or medial lemniscus, it's vibration and proprioception. So far clear?
But doctor, in the corticospinal, didn't we say that if you cut it like before the decussation, shouldn't that be also?
Because it's descending. It's descending, it's not ascending.
Yeah.
Do not mix them up.
So
clear
if we
so
cut
far?
it before the above the medulla, we're gonna have contralateral.
Contralateral.
Below the medulla, it's going to be
On the same side. Yes. So far, so good? Any questions? Any questions? Are we good on that? Now we'll come to the hard stuff. Ever heard about the rule of force?
Yes.
What do you know about it?
Basically, everything that is divisible by 12 is going to be in the midline of the cranial nerves.
We'll start by simple rules. Okay. Let's say that you're looking at the brain from the side of it. Can you see clearly? Let's say that this is the brain. Okay, this is the brainstem, and you're looking at it laterally, like cut myself from here, and you're looking this way. Does it make sense?
Yes.
You can see? Can you see?
Yeah.
Okay. So, which part of the brainstem is this?
Midbrain.
Midbrain. This part that's bulging, bones, and this area, medulla. The first rule, when it comes to rule of force, is that we have 4 cranial nerves in each section. The first section here, midbrain and above, we have 4 cranial nerves, and they are مرتبين, like they're actually like in order. Okay, so midbrain and above, what cranial nerves do we have in this area?
Optic.
Start from the beginning.
Okay.
I told you it's all in order. So the first one, olfactory. Do we care about the olfactory?
No.
Why?
Because it doesn't
Go to the brainstem.
It doesn't originate from the brainstem. Then comes
the
Optic.
optic. Do we care about it?
No,
Why?
because it's also the same thing.
Also does not originate from the brainstem. Then comes
The
oculomotor. Where does it originate from? Midbrain. The upper area of the midbrain, or the midbrain. So we care about it. Then comes the trochlear, just below it a bit. And you see how they are all in order. 1, 2, 3, 4, 5, 6, until you reach 12. Does it make sense so far? So, we have 4 cranial nerves that originate from midbrain and above. Then comes 4 cranial nerves that originate from bones. So we'll continue the order. We finished at the trochlear, 4th cranial nerve. What comes after 4? 5, 6, 7, 8. Trigeminal, abducens, facial, and vestibulocochlear. Where they originate from? Bones. Then comes the medulla, again, 4 cranial nerves, and they are in order. We finished last at 8, so what comes after 8? 9, 10, 11, 12. Is the first rule clear?
Yes.
Is the first rule clear? They are in order, 4 from each section. This is the first rule. The second rule says that those cranial nerves, some of them are medial and some of them are lateral. So if I'm looking at the brainstem anterior view, so you cut me like that and you're looking at me this way. Okay? Is the view clear?
Yes.
Some of these cranial nerves, let's say that this is the midbrain. This is, which side? What's that? Pons. And what's this? Middle. Some cranial nerves are in the middle, and some cranial nerves are on the side. They are lateral. And since this is called the rule of 4, so how many are in the middle? 4. Okay, and those 4, they are divided, or they can accept the division on 12. So let's say 12 divided by 1, and we're excluding 1 and 2 because we don't care about them because they don't originate from brainstem. So we're starting from number 3. 12 divided by 3, does it accept the division?
Yes.
So 3 is in the midline, middle. So this is right and this is left oculomotors. Moving forward, number 4. 12 divided by 4,
Yes.
it accepts the division. So where is it located?
In the midline.
in the midline as well. 12 divided by 5,
No.
it does not
It's going
accept.
to be lateral.
12, so it's going to be lateral. And where did we say trigeminal originates from?
Trigeminal is basically
Pons. Why? Because the first 4 are gone, so we go to the second area. So this is where the trigeminal is located. It's located laterally because it does not accept the division by 12. After 5 we have 6. 12 divided by 6. It accepts the division. So where is the abducens located? In the middle.
of the pons, right?
Of the pons, again. Right. 12 divided by 7.
No, lateral.
It does not accept it. So where should the 7th cranial nerve be located? Lateral side. 12 divided by 8.
It doesn't happen.
Doesn't accept. So where is it located?
Lateral.
Lateral. You know the locations now. Moving forward. This is the 8th. And where is the 8th located, by the way? Lateral bones, right? Now, remember that we said lateral bones. So I'll give you another information about the vestibulocochlear and the trigeminal later on. But in general, this is where they're located. I'll come to more specifics later. We finished the 8th. What comes after 8? 9. 12, does it divide by 12? 12, does it divide by 9? No. So where is the glossopharyngeal located? Lateral medulla. Nice. Then 12 divided by 10? No. So where is the vagus located? Lateral medulla. 12 divided by 11? No. So where is accessory located? Lateral medulla. And lastly, 12 divided by 12? We can. So where is the hypoglossal located? In the middle. In the middle or the medial medulla. This is the second rule. Okay? Everything clear? Any questions?
Yes, but doctor, I'm struggling to memorize the cranial, so if you could just...
Oh, okay. Number 1 is, guys, please help us quickly, the names of the cranial nerves. Number 1 is olfactory. Number 2, optic. Number 3, oculomotor. Number 4, trochlear. Number 5, trigeminal. 6, abducens. 7, facial. 8, vestibulocochlear. 9, glossopharyngeal. 10, vagus. 11, accessory. 12, hypoglossal. We're done by 2 rules of the rule of force. And again, it's called rule of force because we have also 4 rules. Everything is 4 in it. The third rule is, remember what we said earlier on about the contents of the brainstem? We said we have cranial nerves and we have
motor
tracts, right? So we have 4 tracts, 4 are medial and 4 are lateral. The 4 that are medial, so M medial, they are generally M motor. Okay? Remember that we have 4 tracts that are medial and they are generally motor. Remember, I'm saying generally because I have some exceptions.
Yes.
So 4 tracts that are medial and they are generally motor. What tracts that are motor that we know of? A motor tract, a very famous motor tract. Corticospinal. So where is the corticospinal located in the brainstem? So it's medial. No, I'm speaking about lateral versus medial. Remember, I said 4 tracts that are medial, they are also motor. So the first one that we know of that's motor is the corticospinal. And where is it located in the brainstem? Medially. So this is the corticospinal and it spans the entire brainstem. Another motor tract that we know of. So we have the corticospinal, which helps or supplies the entire body, like from neck and below. But what about the face? What supplies the motor function of the face? Corticonuclear or corticobulbar. Okay, so the corticobulbar is the same thing. It's in the midline and it's actually next to the corticospinal. Both of them are next to each other, and the corticobulbar supplies the motor function of the face.
Where was
Makes sense? By the way, it's very important to know it for the syndromes. But sometimes they mix both the corticospinal and the corticobulbar together, but you need to make the distinction. They're different, separate entities, okay? So this is the second motor tract. Another motor tract that, maybe you didn't hear about it, we call it medial longitudinal fasciculus. Medial longitudinal fasciculus, again, it starts, all of them, they start with M. They are all medial, they're all starting with M, MLF. MLF, what happens, or the function of MLF, I'm looking straight, okay? Let's say someone came into the door. So what will happen to my eye? Both of them will look to the left side, right? So this is normal. I'm looking at the left side. These are my eyes. However, if I have a dysfunction on the right MLF, the MLF function is to adduct the eye. This is the function of MLF, medial longitudinal fasciculus. Its function is to adduct the eye. The same thing, the left MLF, to adduct the left eye. So if I lose the right MLF, my eye won't be able to adduct. So what will happen? One eye will go lateral to look there, but the other eye cannot look medial, right? Because remember, it's two eyes, so one will go abduction, the other will go adduction. They have to be following each other. Does it make sense so far? Any questions? So if MLF isn't functioning, would my eye go medial? No. This eye will try to go lateral. However, because both eyes are connected, this eye will go lateral. It will sense that the other eye isn't following it. So it will go back here. Then I'm still trying to look to the left side. It will go back here. It will sense that the other eye isn't following it. It will go back to the normal position. And it will keep doing that. So what do we call that? When you see an eye going right and left? Nystagmus. You see? So the right side is affected, but the nystagmus is happening in which eye? The unaffected eye. This eye is only following the reflex. Does it make sense?
Yes.
I'll repeat it. I need to look to my right side. In order for me to do that, I need two eyes to be functioning, one MLF to be functioning and the lateral rectus to be functioning on the other eye. The lateral rectus, it's okay, it can go to the right side. MLF here, it's responsible for the adduction of the eye. It does not work, so my eye will stay still. It will stay straight. The lateral rectus is working in the right eye. It will go. However, it will sense that the left eye isn't following it, so it will go back to the normal side, or the neutral position, looking straight. Again, I will keep trying to look to my right side, so the lateral rectus will be activated again. Sensing that the other eye isn't following, it will go to neutral position. Again, and again, and again. See? Then the nystagmus happens on the not affected eye. The MLF on the left side is affected, so the left eye isn't adducting, so the right eye will get nystagmus whenever I'm trying to abduct it. This is what we call INO, internuclear ophthalmoplegia. It's a very important concept to know. Does it make sense?
Yes.
Does it actually make sense?
Yes.
Any questions? So this is the third, yes. Yes.
These guys haven't done the pathway for the conjugate vision. So if you have time,
Oh, sure.
so you can just tell them how the sixth nerve, parapontine reticular formation, and the third nerve nucleus are connected.
Okay.
Because what you are explaining, there is a logic behind it. That,
Yes.
why this is happening.
Yeah, definitely. Thank you, Doctor. So in terms of the vision and the conjugate vision, I will touch base on it later on. But yeah, definitely it's an important concept to know. So yeah, this is the third one of the motor pathways that we spoke about. What are the first two? Corticobulbar and the corticospinal. They're all motor. And the third one, which is the exception, is what we call medial. MLF is the third one, but the fourth one I mean. We spoke about three.
Medial lemniscus.
Medial lemniscus. The medial lemniscus, another name of it, if it's in the spinal cord, dorsal column, right? So this is the only exception to the M rule that I gave you. They're all motor except the medial lemniscus, it's sensory, right? So the medial lemniscus, it's an ascending tract, it's a dorsal column, it goes all the way up, it reaches, sorry, this is the medulla, it decussates in the medulla, it goes up as medial lemniscus. So before this, or in the spinal cord, it's called dorsal column. After the decussation, it's called medial lemniscus, and it goes to the contralateral side and goes up.
There is one exception to this rule also. Another exception is that it would remain medial in medulla and pons, but medial lemniscus is not medial in midbrain. So in midbrain it goes a little bit lateral.
Right.
Medial syndromes of midbrain would not affect medial lemniscus. So it goes
And I have great pictures of that. So the exceptions, I'll try to cover them as we go on, because I know I'm speaking about a lot of exceptions. So I'll try to limit them as much as I can until we reach them. يعني. But definitely, again, it's an important aspect to know. So how many tracts did we speak about that are medial? 4 tracts. What are they? Corticospinal. It's the motor function of the body. Then corticobulbar, it's the motor function of the face. Then medial lemniscus, it's what? Sensory.
Of the anything then pain.
So in anything in the heel, it goes back to the dorsal column, which carries which type of feelings or sensation? Vibration. Proprioception. And fine touch.
Yes.
Okay, and the last one is MLF, and everyone knows MLF now?
Yes.
Okay. Do you want to take a break before we speak about the lateral ones? No? We carry on? So, the third rule now is how many tracts we have on the side S. Again, they are 4. And because I'm saying it's on the side S, so they're mostly sensory. Okay? So, what major sensory tract do we know of? Spinothalamic. It's on the lateral side, it crosses at the same level, it goes up, and in the brainstem we still call it spinothalamic. And it's on which side? Is it medial or lateral? It's lateral. So this is the first one that we know of that's sensory. A second one? Spinocerebellar and sympathetic. Spinocerebellar, it carries all the cerebellar information. So if someone, and it's again, it's where is it? Medial or lateral? Lateral. So any damage to the spinocerebellar tract, it will cause ataxia. On which side?
So spinothalamic is also
Contralaterally.
or is it?
Why is it ipsilateral?
It doesn't decussate.
They don't do it. One decussates, but then it goes back again.
So how many decussations does it have? 2 decussations, double crossing. Spinocerebellar has double crossing. So if I cut it up here, it decussates at the thalamus and then decussates at the peduncles. So double crossing. So in the end, if the right brain is affected, the right spinocerebellar is affected. Okay? And where is it located, the spinocerebellar? Is it medial or lateral? So it's lateral, it runs here laterally. This is the spinocerebellar. Then we have another tract, it's called S sympathetic. Remember, all 4 tracts are on the side and they're all sensory and they're all starting with S. Okay? The third one is the sympathetic, and it goes from the sympathetic chain. They find the nucleus of Budge, followed by, I'll come back to it later, but in general, where is it located? Lateral side, and it goes up. And if we damage the sympathetic chain or the sympathetic fibers, what will happen? Where, on which side? Ipsilateral. It does not decussate. Or the sympathetic fibers, they do not decussate. Does it make sense? What are the components of Horner syndrome? Ptosis, meiosis, and hydrosis. Now, someone asked the full ptosis versus partial ptosis. We have two muscles that are supplying or helping us to open our eyes. One is supplied by the cranial nerve number 3, the oculomotor, and the muscle name is levator valvulae superioris. The second thing that's helping us to open our eyes is the sympathetic fibers, because they supply a muscle called superior tarsal. Superior tarsal. Now, if someone loses the function of levator valvulae superioris, the ptosis will be much more severe than the one with superior tarsal dysfunction or sympathetic dysfunction, because superior tarsal is only a small muscle. Okay. However, the one with the oculomotor dysfunction, there will be a major defect when it comes to the ptosis. Does it make sense?
Yes.
Did I answer your question? A stronger muscle is 3, superior tarsal is much weaker. However, do we differentiate between them clinically? Really not. If you see someone with ptosis, you need to find out one of 3 things. Is it the sympathetic fibers that are affected? Is it the oculomotor, or does he have? You took it. Does he have what disease that can cause ptosis? Yes, myasthenia gravis. It's fatigable muscles, right? So this is the third tract. Let's revise quickly. What are the tracts that are on the side, and they are mainly sensory, and they all start with S? Spinothalamic, spinocerebellar, sympathetic, and remember, I spoke about spinothalamic, which carries all the sensation of the body. But what about the face? So the sensory fibers of the trigeminal, they also run lateral, and this is the fourth tract that runs.
Doctor, there was also a PAL tutor who also said that the cranial nerves that were divided by the 12 also are included in the midline group.
Yeah, they are in the middle, right? And we spoke about them. Remember, we draw oculomotor, trochlear, abducens, and 12. Yes. So this is the third rule, or actually the fourth rule. Yes, this is the fourth rule of rule of force. So do we know now all 4 rules? The first one, إيش كانت?
Anything that is different.
4 in each.
4 in each part, 4 in each section. Then
Anything that is
4 medial that are divisible by 12, right? And the third rule is 4 medial, and they're all medial, so they start with the letter M, and they are all motor, with an exception of medial lemniscus. What are they quickly?
we're gonna
Corticospinal, corticobulbar, MLF,
and
medial lemniscus. And then the last rule is we have 4 that are on the side, and they are all sensory. Remember, SSS, and they all start with the letter S. What are they? Spinothalamic for the sensation of the body. What type of sensation? General, اللي هي what would be specific? What sensation? Pain and temperature. Then spinocerebellar. That decussates how many times? Twice. So right-sided will lead to ipsilateral ataxia. Then sympathetic fibers that run laterally, and does it decussate? No. So any damage to the sympathetic fibers, it will lead to ipsilateral Horner. And then lastly, which part? Fibers? The sensory of the trigeminal, which is the face. Now, I have some, let's say, problems with the rule of force. We have some good exceptions. Remember how I told you that we have 4 from each section?
Yes.
The main idea behind the rule of force is now I know where every nucleus or every cranial nerve is located, so I can know if someone presents to me with damage or loss of function of the cranial nerve number 5, 6, 7, 8, I can know for sure that the damage is in pons. Now, why am I speaking about medial and lateral tracts and medial and lateral nuclei or cranial nerves? Because it's not enough for me to say that, okay, I know for sure that this is in the pons. No, I need to know exactly which side of the pons. Is it the lateral pons or is it the medial pons? Okay? So the rule of force will come in handy for us to localize. This is what we call localization. I know the function of every cranial nerve. I know the location of every cranial nerve. I know the location of every tract. So if I see someone with Horner syndrome on the left, now focus with me. I want you to localize the lesion. Someone with Horner syndrome on the left, loss of pain and temperature on the right, deviation of the tongue to the left. With these information, forget the tongue. With weakness of shrugging his shoulder on the left. Give me where is this lesion located exactly. Left lateral medulla. Can I give it another name? What I just lateral medullary syndrome. Just based on the rule of 4, I know exactly where is the location that is affected, and I can know exactly what's the syndrome that I'm dealing with. Right.
So the reason why it's lateral medulla, it's because of the fact that, for starters, the accessory gave it away.
Yes, the accessory told me that which side am I speaking or which location?
Medulla.
Medulla, and which side, medial or lateral? Lateral, because it does not divide on 12. And the second thing that told me that it's lateral is the affected Horner syndrome.
And it also told you the side.
And it told me that it's on the side.
On the left.
Right? Does it make sense? Do you want another example?
Yeah.
Someone
To reinforce.
Someone came to you, to the office, and he has the right eye is looking medial. The right eye, you're looking at him straight, and his right eye is deviated medially. Okay? He cannot move his left side of the body completely. And he does not feel vibration or proprioception on the left side completely. Where is the region located?
Right.
Give me, apply the rule of force. Apply the rule of force. Let's start one by one. The first rule we said, what's the first rule of force? 4 cranial nerves that are midbrain and above, 4 cranial nerves that are in the bones, and 4 cranial nerves that are in the middle. So, if someone is looking at you straight and his eye is looking medially, which cranial nerve is affected? Not the 4th. Abducens, the 6th. Why? Because I do not have the function of lateral rectus, so I know for a fact that this lesion is located in which side or which location of the brainstem? In the bones. Why? Because the cranial nerve number 6, it comes out of the bones, so I know it's in the bones. What else did I tell you?
It's divisible by 12.
It's divisible by 12, so where is it exactly in the bones? Medial side of the bones. And then what else did I tell you? He cannot move his left side of the body.
So it's corticospinal.
Which side of the corticospinal, right or left? Right, because it's before the decussation. Again, right abducens, right corticospinal. And corticospinal, we know it's located because it's motor, so is it located
in the middle?
It's medial, okay? And I said I lost the vibration and proprioception on the left as well.
So it's
Because I have, what's in the middle, another tract? Medial lemniscus, right? So where is the lesion located exactly?
Medial,
Right medial pons.
Right, medial pons. What other name can I give to such a syndrome?
Medial pons.
Yes, medial pontine syndrome. Medial pontine syndrome. Does it make sense?
Excuse me, doctor.
Yes.
Why is his eyes moved to the medial side? Didn't we say if the abduction is affected, then he won't be able to move his eyes medially?
Lateral rectus abducts the eye. If I cannot abduct the eye and I have unopposed medial rectus, what will happen to the eye? Does it make sense?
yes.
Lateral rectus, it's lateral. It causes the abduction. If I lose it, I'm in one of two situations. Either I'm looking straight, or my eye is deviated medially. And most likely my eye is deviated medially. Now when we speak about the brainstem sections, we can also apply the rule of force to identify the structures. Remember, we already discussed all the structures, and if I show you a picture, you should be able to at least tell me what's medial and what's lateral. The only thing that will be missing is what's this location? Is it the midbrain? Is it the pons? Is it the medulla? And we have some clues to tell us what exactly or where are we exactly. Okay?
Yes.
Okay. So here we are speaking about the midbrain. How do I know that this is the midbrain? Without the landmarks. Forget the landmarks, because on the exam you will have a picture with no landmarks whatsoever. Sorry? The cross cerebri? These?
Cerebral aqueduct,
Yes.
actually.
Yes, the cerebral aqueduct. You see how the cerebral aqueduct is surrounded completely by tissue. You see? It's surrounded completely by tissue and it's narrow. So this is the clue that this is the midbrain,
Yes.
by seeing the cerebral aqueduct. Another thing that tells us that this is the midbrain,
Superior follicula.
no, because you will not be able to identify it without the landmark or without the term. Something that's very exclusive to the midbrain.
Red nucleus.
No, red nucleus will look the same as any other nuclei.
Substantia.
Yes, substantia nigra. Even though that this is it looks like here it's white or it's light. This is just because of the staining. But in real life it's black. It's literally, that's why it's called substance black or substantia nigra. Okay? So this line here, the substantia nigra, is another clue that I'm in the midbrain. And the last clue is the way that the midbrain is, the way it looks. No, the cross cerebri, they are like bulging out, you know, like as if he's like a bulky guy like that, you know. Am I making sense?
Yes.
This shape is very specific to the midbrain. And now if I start asking you some questions, we know what cranial nerves come from the midbrain? 3 and 4. And where are they located? Medial, both of them. And since cranial nerve number 3, it's a lower number, so is it higher or lower?
Higher.
So it's higher than the trochlear, right? So if I see the cranial nerve number 3, I know I'm in which part of the middle of the midbrain? Upper midbrain. Yeah. This is another picture just showing us more structures. The main structures that I would want you to focus on are the cranial nerves and the tracts that we discussed. So this is the most medial, and here all the cross cerebri is considered medial. So if they're considered medial, what tracts should I find?
Motor.
4 motor stuff. What are they?
Corticospinal.
Corticospinal, corticobulbar, medial lemniscus,
Medial longitudinal
and medial longitudinal fasciculus. One thing, if you look here, it says lemnisci, right? So one exception of the rule of force, as Dr. Yaqeen said, medial lemniscus, as it goes up, when it reaches the midbrain, it becomes lateral. Okay? It's no longer medially, and it also goes to the back. So this is posterior up here, and this is anterior. The medial lemniscus will start going back and lateral. So do we care about it in the midbrain when it comes to the motor tracts?
Can you repeat what you said?
Okay. The medial lemniscus. The rule of 4 told us medial lemniscus, it starts with M, so it should be medial, right? This is true up until we reach the midbrain. When it reaches the midbrain, it starts going lateral and posterior. So is it going to be affected if the medial midbrain is affected?
No.
No. So this is one exception of the rule of 4s. We don't care about medial lemniscus if it's in the midbrain. Can it localize stuff for us? No, it's bad. And أصلاً in most cases, medial lemniscus isn't even affected because it's so posterior and lateral, nothing comes from the back here and nothing affects it from the medial side. Now, I'm not sure about the syndromes that you took in terms of the midbrain strokes or midbrain syndromes, but I'll speak about 3 main syndromes, and I have some diagrams that hopefully will make it better for you guys. I think we can start.
We took Weber's and Benedict's.
That's all? في واحدة أهم منهم ده اسمها. لا يعني Benedict يمكن هي the most important بس يعني في واحدة is also important. I'll start discussing it soon now. Before I discuss it, I just want to go to the oh صح, I forgot to show you something. What's this in the midline?
Red
What's this?
nucleus.
The red nucleus. Anyone knows what's the function of the red nucleus? Fine tuning. You're right. Fine tuning of age. Yes, movements. So if someone has dysfunction or damage to the red nucleus here, he will have a taxi. That's about it.
Sir, can you repeat what you said?
The red nucleus fine-tunes the functions or the movements. So any damage here will lead to ataxia.
Instead of limit and middle discuss this is
Sorry?
So I'm just saying the red هذا اللي بيسوي
Red nucleus?
So instead of meniscus, for example, we replace it with another.
Exactly. That's about it. Does it make sense so far? Any questions? No questions? Now, if I come to the, oh, by the way, I forgot to tell you about the superior colliculus. What's the function of superior colliculus? Yes? So,
Visual reflexes.
visual reflexes like what? Like for example, we have Muhammad. Muhammad is so bored of the lecture.
No,
So I'm explaining the lecture now, and because he's bored, he stood up and left. I'm looking at you, right? But he's still in my vision. I can still see him. So if he stood up and started going out, a reflex that will happen is immediately my eye will go to him. It detected his movement, so it looked at him. So this is the function of the superior colliculus. Again, if someone...
used to do this.
Sorry?
Like we used to have another cranial nerve that gives us.
That's not as a reflex. That's if I want to do it myself. I want to change the movement of my eye. I want to look left.
Yeah.
That's voluntary movement. This is the reflexive movement.
Oh.
Does it make sense?
Yes.
So this is the function of superior colliculus. Another thing, it's very close to the, what other colliculus we have? Inferior colliculus, and the function of inferior colliculus is? Auditory, right? So another part of this reflex is if someone closes the door or shuts the door really loudly, a normal reflex of my eyes will follow the sound. Okay, and this is a reflex which again is provided by superior colliculus, the vision movement. The hearing is the inferior colliculus. Does it make sense? Okay. Now, when it comes to these things, the tectum, tegmentum, cross cerebri, I just want you to know that in the midbrain we have something that's anterior and something that's posterior. In another name, ventral and dorsal. In another name, actually there are no other names. Just anterior and posterior. When it comes to the posterior or the dorsal, we're just speaking about the tectum. When it comes to the anterior, we're speaking about both tegmentum and crus cerebri. Another name of the crus cerebri is the cerebral peduncle. Remember, cerebral peduncle, not cerebellar. Cerebral peduncle, not cerebellar peduncle. These are different.
Can you just repeat what you said at the posterior?
We have posteriorly is the tectum, and tegmentum and crus cerebri are both called anterior or ventral.
Yeah, but what's the difference between tectum and tegmentum?
It's just when you see this line here, the substantia nigra.
Yeah.
It's what differentiates between the tegmentum and the crus cerebri. Okay. Any questions?
Can we just, you were saying something about the functions of the superior colliculus, and can you just...
Okay, superior colliculus, it's part of a reflex for the eye. If my eye wants to detect something, or my eye is detecting some movement, the reflex is my eye will follow it. It will look at it. This is the function of superior colliculus. If I hear something loudly, a gunshot or something, immediately I will look at it, right, as a reflex. I'm not doing it voluntarily. Why? Because I have an intact superior colliculus. Now, when it comes to the superior colliculus dysfunction, that's very rare. You will never hear it. Yumkin maybe in residency in neurosurgery, you hear it once or twice. It's very rare, really.
Thank you.
No worries. So this is the upper midbrain. The lower midbrain is basically the same. It looks the same. The only thing that's different is trochlear nerve. Trochlear nerve is a very small nerve, and it's special because it's the only cranial nerve that originates or goes posteriorly. Makes sense? It goes posteriorly here, you see, and it crosses. Now, when we speak about the syndromes, as I told you guys, we will follow the same criteria or the same classification, that we have syndromes that happen posteriorly and syndromes that happen anteriorly. Okay? The first of all is let's say the most common of them is a syndrome. Why doesn't this move? Okay, doesn't. This one. Whatever is affected here in the red line, can you name the structures? It's anterior and medial. I'll just make it easier for you. It's considered anterior and medial. So what do we have medially? Corticospinal, corticobulbar,
Medial
MLF, medial lemniscus. This is midbrain, so do we care about it?
No.
No.
We have the red nucleus.
What else in the midline or medial? Cranial nerve.
Third.
Even though that I know I'm only highlighting this area, but look what's affected here. So I'm not affecting the nucleus itself, but if the blood supply is gone entirely here, the fibers here still, the axons, they still need some blood supply, right? So it is affected here. So, since you named all these structures, you said corticospinal, corticobulbar, what else? And third, the cranial nerves. These are the ones that I care about. So can you tell me, if I have a stroke here, what will be, and this is which side, left or right? Right or left? Who goes with right? Right? Who goes with left? Well, it's right. Yes. Why? Because this is an inferior view. It's the same way that we see the patient. It's like a CT scan. It's flipped. Right is left and left is right. So I have the right anterior medial midbrain is affected. Right anterior medial midbrain is affected. So we said the right corticospinal, the right corticobulbar, and the right MLF, and the right not trochlear, oculomotor. So let's start. I'll come to that later. Still here, the red nucleus is affected here. So can you give me the signs? How would the patient look like? Start by one من الأربع أشياء اللي you mentioned. Left-sided spastic paralysis. Do you agree with him?
Yes.
Why?
The
The right corticospinal is affected. That's number one. Number two, corticobulbar. So what will happen? This is wrong. The corticobulbar, this is something tricky. The corticobulbar decussates. The corticobulbar decussates. Not all of it, but one specific thing that decussates fully. Facial nerve is around like 60% decussates, so that's important. And one that decussates fully is the hypoglossal. It decussates fully. So, and the facial nerve is also affected. So if it decussates, what will happen? The corticobulbar, this is very specific to the midbrain. Do not apply this rule in anything other than the midbrain. The midbrain is the only thing that you need memorization in. Other than that, bones and medulla, you will apply rule of fours and you will be good. The midbrain is the only thing that's very specific and needs shوية memorization. The corticobulbar, it's still, we are high up in the midbrain. The corticobulbar for the facial nerve and the hypoglossal, they decussate here or below that a bit. So what will happen if the right corticobulbar at the level of midbrain is affected? Contralateral facial paralysis and to the opposite side. Because I know in the lecture everyone tells you if the hypoglossal is affected, the tongue will deviate to the side of the lesion. This is all true except in midbrain. And what do we call that? Because when we say a bulbar palsy, so we are losing the function of the corticobulbar tract, lower motor neurons of the face, lower motor injury to the motor function of the face. This is bulbar palsy. However, because in midbrain it's so specific and it gives us a false localization, it goes contralateral, so it's not a bulbar palsy, it mimics the bulbar palsy, so what can we call it? Pseudobulbar palsy. Pseudobulbar palsy is an upper motor neuron injury to the corticobulbar tract before the decussation, so it will lead to a false localization, contralateral bulbar palsy. Upper motor neuron, not lower motor neuron. هذا الهايبوغلوسال نيرف، لكن قبل ما يصير نيرف في فايبرز تبعته تراكت، هو descending tract، صح؟ The hypoglossal nerve, it's only in the medulla, that's the nucleus of the nerve.
طب أجل, what's the use of like knowing where each nerve is in the brainstem? إذا يعني if the tract, like this has confused me.
Yes.
أنا يعني إذا if the corticobulbar is damaged at like let's say midbrain, then it's gonna affect the tongue, and then it's like how do I differentiate that from like a medullary syndrome?
الحين راح أقول لك. أول حاجة بالنسبة للميد برين هو اللي راح تكون confusing. أما other than that بالبونز والميدولا راح تكون very straightforward. طيب why is that؟ عشان راح تكون on the opposite side. بالميدولا راح يكونوا كلهم on the same side, same face, same side of the body. Or sorry, same face, the contralateral side of the body. But in this case, it's same face and same side of the body. Both are ipsilateral. Here both are ipsilateral. بالbrainstem اللي هي bones and medulla specifically راح يكون one on the lateral ipsilateral اللي هو الفيس, and الهيمiplegia راح تكون contralateral. Does it make sense?
Yeah.
And this is very important concept when we speak about internal capsule. Ever heard about the internal capsule?
Yes. Very brief.
So the same thing happens if the internal capsule is affected. It will be same face, same side of the body. In the brainstem is where things get the opposite sides. Left face, right body. Right face, left body. طيب? In the midbrain is شوية confusing because it's literally the connection between the internal capsule and the bones, and it's very confusing, so you need to do some memorization here, unfortunately. You need to do some memorization.
So in the midbrain, basically, what we're saying, contralateral.
Yes, راح يكون contralateral body, contralateral face, upper motor neurons, and oculomotor is the only one that's ipsilateral. The only thing that's ipsilateral is the oculomotor.
But I don't want to just memorize that. So oculomotor, the reason why it's gonna be like ipsilateral, why is it?
بس هي شوف كيف طالع. You see it?
Because it's on the same. I mean, if it's
It's on the same side.
there isn't. Okay.
ما في indication whatsoever.
Yeah.
What happens to the tongue again?
The tongue will deviate opposite side, to the opposite side, away from the lesion. And this is, honestly speaking, in midbrain strokes is like a fellowship level or residency level. Honestly, I mean, that's my opinion. I'm not going to go into politics. I mean, I need my job. But it's really confusing. I understand. So this is basically it.
Can we recap the syndrome?
Yes.
Okay. So, it affects the anteromedial midbrain. Three main structures that I would want you to memorize: corticospinal, corticobulbar, and the oculomotor. Oculomotor, since this is the right oculomotor, so what will happen to the eye?
It will look laterally and down.
Out and down.
Ipsilaterally.
Ipsilaterally, out and down. Then comes the corticospinal. It's very straightforward. حيكون left-sided hemiplegia because this is the right corticospinal. Now the corticobulbar, because this is midbrain, we have some fibers that decussate, some doesn't. That's why I say, it's confusing. It's confusing. The one thing that decussates is the facial nerve and الهايبوجلوسال. But is it clinically important? In reality not. What we care about إنه حيكون الfacial nerve حيكون on the same side as the body. Left face, left body. Right face, right body. We don't care about the hypoglossal. If they mention the hypoglossal, it will be away from the lesion. On the opposite side of the tongue will deviate away from the lesion. If they mention it, they should not mention it because again, it is confusing. But I read, you told me that they mentioned the Weber, or I read it in one of your slides. So this is the Weber syndrome.
Excuse me, doctor?
Yes.
What about MLF?
MLF, I won't care about it honestly. Although it can be affected. And if it gets affected, what will happen? We explained it. Nystagmus on which eye? This is the right MLF.
On the right side.
On the right eye, it will get nystagmus. The opposite eye, the left eye will get the nystagmus, and the right eye won't be able to adduct, look toward the nose. The right eye cannot look toward the nose. The left eye will get nystagmus. And what do we call this condition? Internuclear ophthalmoplegia. Internuclear ophthalmoplegia.
What was this?
تكلمنا عنها اللي هي اللهم صل على محمد.
اللي لما واحد يطول يمين على العين حقته على اليمين.
Yes. And since this is upper motor neuron بالcorticobulbar, so the corticobulbar upper motor neuron. So remember how بالcorticospinal we have upper motor neuron. What does it do?
It's controlled.
تكون spastic paralysis. Can you think of a spastic paralysis in the face and tongue and the mouth? Any spastic paralysis? تكون spastic dysarthria. They talk hardly. They cannot talk. They like. I don't know. Honestly, it's on YouTube. But yeah, it's very specific to it. This spastic dysarthria. They cannot talk well because everything is contracted. Everything is contracted. They cannot talk well. Spastic dysarthria. And this is what we call which syndrome? Weber syndrome. Is it anterior or posterior syndrome? Anterior. What do we care about? Three structures: corticospinal, corticobulbar,
And
oculomotor. Okay, and we know the manifestations. But if I do this is another syndrome which is not mentioned in your lecture. فما بعرف. Do you want me to skip it?
Yes, yes.
No.
don't skip it.
So this is what we call cloud syndrome or Claude syndrome, depending on your pronunciation. Can you tell me what structures are affected here? Red nucleus and oculomotor and possibly MLF.
Yes.
This syndrome is completely or a pure tegmental syndrome. The first one كانت pure anterior syndrome, pure cross syndrome. The second one is a pure tegmental syndrome, and the third one will be
Pure.
no. Yes, it will be a combination. The third one will be a combination of both. So the first one is a pure cross syndrome, the second is a pure tegmental syndrome, and the last one is a mix of both. Okay? Does that make it شوية easier?
Yes.
Okay. Tell me the structures that are affected. Someone said oculomotor, the second said red nucleus, and the third one MLF. Do I care about MLF that much? Not really. Because in the end here, MLF is so high up, it will start separating, and each will go to its needed location, so on and so forth. But it can happen. It can cause internuclear ophthalmic lesion. But this is which side again, right or left? Right. Which oculomotor, right or left?
Right.
Right. So what will happen to the right eye?
Out and down.
Out and down. What will happen to the pupil? Dilated pupil. Nice. What else will happen because of the red nucleus? Ataxia. To which side?
On the right. Is there deviation?
It's the same side. Ataxia on the same side, right?
So basically,
Remember the
everything is
devil.
gonna be on the right side.
Yes. Right tegmental syndrome or right tegmental stroke will lead to right ataxia, right cranial nerve 3 pulse. These are the only things that I need you to remember. What do we call this? Claude syndrome. Claude syndrome is a pure tegmental syndrome. Yes, that's about Claude. And the last one is a mix of both tegmental and cross. So what are the structures that are affected? Corticospinal, corticobulbar, MLF. We don't care about it, but it's okay. It can happen. In fact, in this syndrome, I care about MLF.
Yes,
In this syndrome, I care about MLF. In this syndrome only. What do we call it? What do you call this syndrome? Benedict syndrome. Benedict syndrome is the only midbrain syndrome where I care about MLF. The others, they rarely cause or internuclear ophthalmic lesion. Okay? So that's MLF. And what's the structure? Oculomotor. What's the structure? Red nucleus. What's this? This substantia nigra, and here corticospinal. So, which side is it, right or left?
Right.
Right. So what's affected? Right corticospinal. What would it cause? Contralateral what? Spastic paralysis. Nice. What else we have? Corticobulbar. In Benedict, I wouldn't care much about it, but again, what will happen if it happens? It will be on the contralateral side, the same as the corticospinal tract. And the second thing, or the third thing, sorry, is, which structure is this? Red nucleus. So what will happen? Ataxia to which side? Ipsilateral. Ataxia is always ipsilateral. Cerebellar signs are always ipsilateral. I don't think they will tell you anything about the cerebellar signs that are contralateral. Because again, it's advanced, it's confusing, it's rare, no one cares about it, really. They shouldn't care about it. So this is the red nucleus, and the last one, oculomotor, what will happen? Ipsilateral, out and down with blown pupil, dilated pupil, blown pupil, all the same.
Can I recap it for you?
Yes, please.
Before that, Dr. Howard,
Yes.
Since the substantia nigra is affected, does that lead to dopamine syndrome?
Yes, it will lead to some movement syndromes, most notably Tremor happens, yes, but athetosis. Athetosis is what I care about. If they mentioned athetosis with lateral or contralateral hemiplegia, this is Benedict. It should be Benedict. If they mentioned athetosis with it.
Doctor, what's athetosis?
Athetosis is like a movement of the fingers, dancing fingers, even. Like, or they cannot stop moving their fingers.
Doctor,
Yes.
على red nucleus effect. I'm not sure if it's the same thing as ataxia, but in our slides mentioned that it's going to be like contralateral tremors and hemichoria. I'm not sure what that is, but
Contralateral tremors.
yeah, contralateral intention tremors and hemichoria. First of all, what's hemichoria?
Korea is the dancing movements.
Oh,
Okay, but maybe that's because of the substantia, not the red nucleus. Red nucleus is
It says destruction of red nucleus, contralateral involuntary movements.
I'm not sure about that, honestly. I'll double check or I'll get back to you.
Okay.
Okay? And thank you for noting this out. I'll double check it or I'll tell you.
Thank you.
No worries. Yeah, I'll double check it, inshallah, now. These are the syndromes of midbrain. We have one that is purely cross. So the main things that will be affected, corticospinal, corticobulbar, and oculomotor. We have one that's mainly tegmental,
Which is going to be the
red nucleus, and oculomotor. That's the ones that I care about. And the last one is the mix between them.
I want to say.
Yes.
So for starters, we're gonna have affections of the medial meniscus, and it's
Medial lemniscus, we said it's in the midbrain, but we don't care about it. Medial lemniscus should never be mentioned in the midbrain. Because what does it do?
medial meniscus, I guess.
It will start going laterally and it will start going also posteriorly. Do we care about it in the midbrain? No. Don't ever mention medial lemniscus.
Okay, so the corticospinal, it's going to be contralateral spastic paralysis.
Jameel.
And then we're going to have affections of the oculomotor, so it's going to be out and
Out and down.
down.
And what side?
It's going to be ipsilateral.
Ipsilateral, nice.
And this is going to be contralateral, the spastic paralysis.
Jameel.
And
the last one here.
Here, what is it? Oh, the ataxia.
Yes.
Is going to be ipsilateral, and also we're gonna have the dopaminergic, basically. This,
Yeah, athetosis or movement disorders. I think this would be beneficial بالفاينل because you're taking the movement disorders later on. Okay, so this is the. Wait, when is our lecture finishing? 2? Okay. Yeah, we have time. Inshallah. So these are the anterior midbrain syndromes. We have some syndromes اللي هم posterior, but we don't care about it that much. Maybe you guys will mention it. اللي تعبوا عليها Barry syndrome. Ever heard about it?
Yeah,
Yes? No?
we did.
So basically the pineal gland, you know what's the pineal gland?
Yeah.
What's the function of pineal gland?
Sleeping.
Melatonin.
So guardian rhythm.
Melatonin and sleeping, right? So the pineal gland actually lies here, around behind it here, like somewhere here. Okay? So behind the midbrain here, somewhere here in the middle. So let's say there is a tumor in the pineal gland. We call it pinealoma. So it will start compressing the colliculi. What will happen if you compress the colliculi, especially the superior colliculus? This is something, another reflex that I did not mention about the superior colliculus is the vertical gaze. If I want to look up, I need superior colliculus. If I don't have that, so my eyes will be down. Okay? So we call it vertical gaze palsy. And here we have the, I think it will be the reticular activating system. I'm not sure. Let's forget about it for now. Not needed. Okay. Assalamu alaikum, everyone. Quick recap. was hearing here someone saying corticobulbar is sensory. Corticobulbar is never sensory. It's never sensory.
It's cortical. It's coming from the cortex. خليه sensitive.
ليش قاعد تيجي من الكورتكس لا تعرف sensory؟
What is?
ايش هي؟
ايش
What ascending tract do we have that goes to the cortex?
لا with descending.
Oh, descending. Okay.
Descending ما يصير sensitive صح؟
Okay, yes.
صح؟ إيه.
Yes. طيب. Just a quick recap about the midbrain syndromes. We have one that is pure cross syndrome. We have one that is pure tegmental syndrome, and one that is mixed. طيب. اللي pure cross syndrome اللي هي اسمها Weber syndrome. Weber syndrome affects three things that I want you to remember. Best three things. اللي هي corticobulbar, corticospinal, and the third nerve. Corticobulbar,
Left-sided spastic paralysis.
left-sided facial spastic paralysis. This is the only one that I want you to remember. Left-sided upper motor neuron of the face. Okay? And how would it look like also? Because of its pseudobulbar palsy, so the spastic or spastic is arthria. Okay? The second thing, corticospinal, so it will lead to contralateral spastic paralysis of the body. And the last one, oculomotor nerve, so it will lead to ipsilateral, down and out with blown pupil. So this is Weber syndrome. The second one, it's a pure tegmental lesion. We call it Claude syndrome. Two things that are affected, oculomotor and red nucleus. Okay, what would happen if the oculomotor is affected? Which side first? Ipsilateral. Down and out. Now, when it comes to the red nucleus, your colleague said that in the lecture it says contralateral ataxia, and this is correct. I made a mistake, I said it's ipsilateral. It's actually a contralateral ataxia. Which takes me back again to the midbrain strokes and syndrome are very complicated because we have so many decussations. And here, this is where one decussation happens of the spinocerebellar tract. Here, this area, I'll show you now a gross picture, how the superior cerebellar peduncle goes here to the red nucleus, like it comes from behind and goes here, and then some decussation happens. So it's شوية confusing, I know, even myself I'm confused. Yes, I made a mistake. Left-sided or right-sided red nucleus will cause a contralateral ataxia. Red nucleus is affected, leads to contralateral side or ataxia. And this is what we call which syndrome? Claude syndrome. It's a pure tegmental syndrome. There is no involvement of the face. Okay, pure tegmental, no corticobulbar or corticospinal. And this is the last one, we call it Benedict syndrome. It's a mix of both. So the red nucleus is affected, we have the oculomotor is affected, MLF in many cases it is affected, and lastly the corticospinal is affected. 4 structures, in many cases it's 3 if we exclude the MLF. The oculomotor on the right side is affected, so what will happen? Ipsilateral, down and out. So this is the oculomotor. Red nucleus, it's affected. Contralateral ataxia. Substantia nigra, if it's affected, it can lead to some movement disorders. And lastly, what I care more about it is the corticospinal contralateral hemiparesis. Okay? 4 structures, sometimes 3.
Corticospinal, oculomotor, red nucleus, and
الMLF. Okay.
Did you say ataxia was same-sided?
I was saying that, but I was wrong.
Oh.
So it's contralateral ataxia.
Is it because the fibers cross?
Yes, there are double crossing, and this is area of like before the crossing, before one of the crossings. So it's between two crossings. It acts as if it's like one cross.
And Benedict is still considered a medial midbrain.
We call them the ventral midbrain syndromes. All of them, they call them ventral midbrain syndromes. One that is purely on the cross cerebri, the second is tegmental, and the last is a combination of both. Do you need them for your exam? Maybe Weber and Benedict,
Yes.
Claude, it wasn't mentioned. Yes, do you need them in step 1 exam?
Probably.
Yes.
There was one question in the entire 4,000 question bank about it. About Weber only, not even both. Okay, now speaking about the bonds. Remember, what did we say about how can we recognize the midbrain? Cerebral aqueduct, that's number 1. Number 2?
The crest.
Not red nucleus. Red nucleus will look the same. How can you tell this is not red nucleus? صح? Red nucleus literally is colored the same way here as the bonds. So substantia nigra, you will see a clear-cut white line, and the last one is the crus cerebri, how it's looking like bulky, it's sort of like outward and bulky. طيب, this is good. Now in the bonds, let's go back to the rule of force.
Doctor.
What would we have in the?
Sorry,
No.
you said the identification for the midbrain is the Niagara and what?
Substantia nigra,
And
اللي cross cerebri, and cerebral aqueduct اللي هي أهم واحدة.
yeah.
Cerebral aqueduct. Now here, as I told you, cerebral aqueduct is completely surrounded, right?
Yes.
طب, sorry. In this case, here it's all surrounded. But what's the difference? But how can I say this is not the cerebral aqueduct? It's bigger, that's number 1.
There's cerebellum.
Cerebellum is behind it. You see? In the other case, it's all homogeneous. Let's go back to the picture of the medulla. And it's all homogeneous. You see? It's all looking the same. Here, the histology changed. You see the difference? Does it make sense? Sometimes they would cut off the entire cerebellum and you will end up with an open-ish fourth ventricle. So the entire cerebellum won't be here and you will see this actually open. Like it's not surrounded completely. طيب. How do I know that this is not the medulla?
The olivary.
Yes, the inferior olivary nucleus. What's the function of the inferior olivary nucleus?
Sorry?
Inferior olivary nucleus.
Yes.
Function.
Um,
Yes, we don't know.
they didn't mention.
We don't know.
They just said.
Because they don't know.
Really?
Yeah. We don't know the function of inferior olivary nucleus. Maybe now we have new theories. This, up until now, it's all theories. We don't really know the function.
This inferior olivary nucleus is only found in the medulla, right?
Yes. So it's only found in the medulla, and it has a characteristic shape. So if it's not present, and I don't have the cerebral aqueduct, both are absent. So I know for a fact that I'm at pons.
And we
No cerebral aqueduct and no inferior olivary nucleus. This is the pons. Okay.
We're gonna have the 6th, the 7th, and the 8th.
Now coming to the question, we have how many people here? We have around 15 people or 20 people, 15 people. I want every single one of you to give me one structure that's present in the pons and give me where is it located, medial or lateral.
Okay.
So starting by you at the top. Give me one structure that's, without looking at the picture, give me one structure, cranial nerve or tract, that's present in the pons and tell me where is it located, lateral or medial. Start. Corticospinal, where is it located? And another name, medial or lateral? Apply the rule of force.
So it's median.
So it is
Median.
medial. So corticospinal. Another thing, you. Behind, yes.
Corticobulbar?
Corticobulbar, where would it be located?
Medial too.
Medial, exactly. And this time the corticobulbar has already decussated. So any damage here will lead to
Where does it
ipsilateral,
decussate?
at the level of the midbrain.
Okay.
Yes, do you need to know that? The only thing you need to know it in the midbrain only. Other than that, it's always ipsilateral. طيب? So corticobulbar, and you said it's located medial or lateral?
Medial.
Medial. Then
Abducens nerve. Medial.
abducens nerves, cranial nerve number 6. Where is it located? Medial. You.
Cranial number 5, trigeminal.
Trigeminal. Lateral. Okay. You.
Facial nerve.
Facial nerve. Where is it located?
Lateral.
Lateral.
Vestibulocochlear.
Vestibulocochlear. Where is it located? Lateral. Next.
Medial lemniscus and it's medial.
Exactly. Next.
Spinothalamic lateral.
Spinothalamic. It's lateral.
Medial longitudinal fasciculus.
Medial longitudinal fasciculus.
Medial.
Medial.
Spinothalamic lateral.
We said it.
Fourth ventricle.
Apply the structures. I'm not speaking about the anatomy. Apply the rule of force. Or try to go one by one. Dorsal column, they mentioned it. It's no longer named dorsal column, it's named medial lemniscus. They mentioned it.
خلصنا الميديال من الرول.
نعم ما خلصنا. I'm telling you ما خلصنا. Oh wait, sorry. Yeah, you're right. The medial stuff من ناحية الموتور tracts we're done. We named 4.
Oh, sympathetic tract.
جميل. And where is it located?
Lateral.
Lateral. Then
Cranial nerve 5.
cranial nerve 5, they mentioned it and they said it's lateral. Another cranial nerve.
No, they mentioned
They said 5, they said 6. They didn't say 7. 7, where is it located?
lateral.
Lateral. Then we mentioned 4 cranial nerves, we mentioned 4 motor pathways or medial pathways, and we mentioned the 3 of the sensory pathways.
Did we talk about the spinocerebellar pathway?
And the last one is spinocerebellar. So 4 and 4 and 4. Remember, apply the rule of force. 4 structures اللي هم cranial nerves. هنا in this case one of them is medial. صح? Then 4 motor pathways that are medial. ما عدا واحد منهم اللي هو medial lemniscus is an exception. It's sensory. And 4 lateral sensory pathways. And we mentioned them اللي هم spinothalamic, spinocerebellar, sympathetic, and the spinal trigeminal, or not the spinal trigeminal, يعني اللي هو sensory of the face, sensation of the face. We have a sensation of the body, okay, and we have a sensation of the face. Okay, it's a different tract than the trigeminal nucleus itself, although they mix them both together. طيب, everything clear?
Yes.
These are the structures of pons. Let's look at them. Oops. Oh, no. Okay. So here in the midline, it's medial longitudinal fasciculus. Sometimes they show you the medial lemniscus here. Sometimes they put it as a straight line. Most likely, when it's a straight line, you are in the if it's marked, يعني. You are in the middle if it's a straight line. But still, it's a midline structure or a medial structure. Now here to the front, this bulging area, we call it,
Basilar.
okay, it's basilar or ventral, but it looks like, or it doesn't look like it, but they call it the pyramids basically. Okay, and it goes down to the medulla as well. And I'll show you now. So this is the medulla, and this is what we call the pyramids. It's most likely when we say pyramids, we're speaking about the medulla. But still, you can name them also the pyramids here in the pons. We spoke about the cranial nerve 5. It's located laterally. Why this is the pons? Because of 2 criteria.
The cerebral aqueduct.
There is no cerebral aqueduct, and the second criteria is no inferior olivary nucleus. Can you identify the bones if I show you a cross section like that?
Yes.
The first thing you do whenever you see a cross section is identify which part of the brainstem you're at. Midbrain, what are the criteria? Cerebral aqueduct, cross cerebri, substantia nigra. Red nucleus you cannot see yet, you cannot differentiate between a red nucleus and any other thing.
Okay, I realized that.
Okay?
Yeah.
طيب, the bones, how do I identify it?
Fourth ventricle.
Fourth ventricle, sometimes it will be surrounded by cerebellum. If I see cerebellum, this is bones. Most likely they will remove the cerebellum. So the fourth ventricle will be open. Okay, however, the same thing happens with the medulla. The fourth ventricle will be open. So I cannot use the fourth ventricle as a localizing area or just by looking at it. Although yes, it is bigger. It shows me the angle of the fourth ventricle. I can say for sure this is the fourth ventricle, but something more specific is there is no cerebral aqueduct that's fully surrounded and tight. And the second thing is there is no inferior olivary nucleus. Make sense? But you're totally right. Cerebellum and fourth ventricle are localizing signs or sites for the bones. This is a cartoon showing you the trajectory of, I just wanted to show you the trajectory of the facial nerve. This is the facial nerve here. And before it emerges, it goes and loops around the abducens nerve. Why is this important?
Facial connectivity.
It makes the bone.
No. Give me a clinical importance. I don't care about anything except the clinically, which will be the major bulk of your exam, by the way. So we said the cranial nerve 7 is a lateral or medial structure?
It's lateral.
Lateral structure, right? طيب, but it loops around medial structures. So normally I know for a fact that some part of the facial nerve is supplied by medial blood vessels. So if the medial blood vessels died, sometimes I would have facial paralysis as well. Is this important?
Yeah.
It is like rare. We don't care about it, really. And to make your life simpler, when you see a facial paralysis, you know that you are in lateral bones. Don't complicate your life. So, well, sometimes it's medial bones, sometimes it's lateral. I know the statistics happens 1% of the time. Don't do that to yourself.
طب can't we differentiate إنه مثلا if it's a dorsal lesion ولا a ventral lesion or that's the
No need to know that. No need to know that, and you will not differentiate it clinically. Because I will draw you now the blood vessels and you will see how they're correlated. And again, when I draw the blood vessels, I will ask you to apply rule of force. You should apply rule of force in everything. It will make your life easier. You will be able to localize. For now, I just wanted to tell you that, even though the facial nerve is a lateral structure, and what we care about is the nucleus itself, but it wraps around the medial structures. Sometimes there would be a facial paralysis even in a medial pontine lesion. But it's rare, forget about everything I just spoke about. I'm sorry. So let's say that I have a lesion here. So where is the lesion?
Medial.
Medial what?
Medial one.
Which part of the bones, right or left?
right?
Right. So I have a lesion in the medial right bones. Give me the signs and symptoms of the patient. 8 things. I want you to mention 8 things. Yalla.
Okay.
Corticospinal is affected. What will happen? Where?
The left side.
Contralateral spastic paralysis. That's number 1. What else?
We're also going to have the adducens nerve is going to be affected.
So, cranial nerve 6 palsy. What will happen to the
The eye
eye?
would
And
move
down.
inward and down.
Inward.
Not
Only inward. Adducens is lateral rectus. You lose it, it goes in.
Okay.
So that's the second sign. The third sign? Corticobulbar. What will happen? Ipsilateral facial paralysis or
Okay.
بس هنا
here على cortical bulbar الحين احنا في البونز صح؟ فتحتها في الميدلا we have like 10, 11, 12 and 9.
Right.
What happens to those؟ لأنه احنا في
not
البونز.
affected.
طب بس cortical bulbar يعني don't they
ما
send-
cortical bulbar الفيس
بس
بس اللي هي بس الفيس. أنا this is what I care about. I will not care about anything else.
يعني لما
Really?
نقول cortical bulbar affected
أيوة.
what's the effect؟ What's 6
facial
الفيشل
بس
nerve.
facial
بس
nerve.
لكن do I care
What
about
about
it
the other
much?
cranial nerves?
Again لا not affected. لكن do I care about it much? لا ليش؟ عشان medially يعني in general if we are speaking about medial stuff the facial nerve is here you know يعني الكورتيكو بالبر تراكت is up higher شوي لكن هنا خلاص وصل اللي هنا صارت يبدا يعني
What about
اوكي
تحت؟
التراكات let's say في عندنا اوكيلو موتور صح؟
إيه.
بيجي سم كورتيكو بالبر اوكيلو موتور يعطي الفايبرز فصار اصغر الكورتيكو بالبر اجى تروكيا صار اصغر وصل لحد ما نوصل هنا صار قريبين الكورتيكو بالبر فايبرز
بس لسه في fibers in
قليلين
9
جداً.
10 و 11
I know لكن we don't care about them they're okay not
Why are
affected
they okay?
they're okay عشان هنا اصلا بيكون already يعني what we care about the major descending tract راح يكون الكورتيكوسباينال corticospinal I will not care about الكورتيكوبلبر much
طب why did we care about it لما كان
بالspine.
mid brain
بالميد برين عشان الميد برين is confusing الميد برين is confusing I know
طب بعدين وصلنا للبونز okay and we have the cortical bulbar tract ليش okay I get it it's the fibers are less but why aren't the cranial nerves اللي تحتها affected too أو cranial
okay
nerves?
I understand your question I don't have the best answer to it but I'll just say I don't know طيب
Dr. Yaqeen.
Yeah, Dr.
Perfect
Yaqeen.
timing, doctor. So,
yeah
yeah, you can go
We
ahead.
have the corticobulbar tract coming from the brain and it goes down and if we reach and we know it's medial so if we reach the bones and we have the medial pontine syndrome is the corticobulbar tract affected and what would happen to the nerves of
So
the cranium?
mainly the fibers which are related to hypoglossal nerve are affected because those are the medial motor fibers going down to the hypoglossal. Nucleus empiricus, I don't know, but mainly the hypoglossal
Yes.
fibers are affected, and that's why in the medial pontine, certain medial pontine syndromes, you also would have a problem in terms of, in terms of swallowing or speaking because of the inability of the tongue to move. Yeah, inability of the tongue.
Kind of.
So hypoglossal, the upper motor neurons of the hypoglossal maybe.
Okay, so can we
It's the
apply
same.
the logic that, like, I'll just go part by part. Let's say we're in the midbrain. Can we apply the logic that when the cortical bulbar is affected, it would also affect, like, all the cranial nuclei below it, or?
Yeah, it is, but mostly what you are going to see when it is midbrain and the corticonuclear fibers are affected, the most pronounced thing which you are going to see is the upper motor neurons of the facial nerve. So you would see contralateral half side of the face paralyzed with forehead sparing. That would happen if there is a midbrain lesion involving corticonuclear fibers. And if it is the pons, you usually see with the locked-in syndrome.
Yeah.
And what you would have is that because you would not be able to move your tongue, so the guy is not able to speak, he cannot move the arms and and because both facial nerves are affected, so it's both both sides half facial expression is also gone, and both abducens are affected, so the eyes are not moving. But the main corticonuclear fibers which are affected in locked-in syndrome are the fibers which are going to the hypoglossal nuclei. And that's why the tongue cannot move. And because tongue cannot move, you cannot speak. So it's not the nucleus ambiguous on both sides, because otherwise the vocal cords will come in the center and you would not be able to breathe.
But why doesn't it?
Because they are laterally located, those fibers.
Oh. So when we say corticonuclear tract, we don't mean the entire thing, but like...
Yeah, the fibers would also be going in the same orientation. The motor nuclei, which are more medially located, the fibers are going in the center. Those which are located more laterally, like nucleus ambiguous, they are more laterally located.
Is there like a pattern to how they're located? Like what I'm thinking initially is that hypoglossal would be more lateral because it's like one of the...
Hypoglossal is in the center.
Right.
Yeah.
Sorry.
Yeah.
No. So at like the same way that the nuclei are...
The same way the fibers are going to
Okay. Thank you.
I got a little bit confused. So it's a little bit tough. So like if you don't mind recapping a little bit, just the cortical
nuclear fibers.
Yeah.
So corticonuclear, if they are affected in the pons, and especially in the with corticospinal, the medial fibers, they are the fibers which are going to the hypoglossal nucleus. So they would affect the hypoglossal nucleus, and hypoglossal is important for the movement of the tongue. So then you would find features like inability to speak, maybe dysphagia because you cannot move the tongue and push the food back, and that's what is going to happen. If it is in the midbrain, the fibers, the corticonuclear fibers which are going down from the midbrain to pons are mainly going to affect the facial nerve. So what you would have is the upper motor neuron type of lesion involving the facial nucleus, which is contralateral half side of the face with forehead squaring.
Thank you.
So that would give you where it is.
So if it's
And one last question, which is very basic, and I think I should know it, but still. So the motor parts of the cranial nerves are the ones that are going to be affected in the cortical bone, right? Only motor.
Just take that one for the
Just wanted to confirm.
Because sensory tracts are going up.
Yeah, right. Thank you. Yeah, I just wanted to this is the same.
So basically,
Yes.
basically, if we're gonna, basically what I've understood, basically we're always gonna affect the cortical nucleus, but if it's in the midbrain, it's gonna affect the facial. If
Yes.
it's
To be more, yeah.
hypoglossal and dysphagia.
However, we use the hypoglossal to sort of localize for the medulla. Even though this is very true, it happens, like for your level, if you see the hypoglossal affected, think about the medulla.
Yes.
Okay? And corticobulbar, more helpful than midbrain. Okay? Other than that, try to شوية forget it. We'll come to them.
The reason also why hypoglossal is not going to be affected by unilateral corticonuclear fibers affected is because it is supplied bilaterally by so upper motor neurons are so for each each hypoglossal nucleus you are getting bilateral supply from both cortices, the upper motor neuron. So if you are going to only affect the half side of the basilar part of the pons, still the supply of the upper motor or corticonuclear or hypoglossal from the other side is coming. So it will not be affected unless there is bilateral, corticonuclear fibers affected in the pons, which happens in locked-in syndrome. You would not have this type of.
Thank you so much, doctor.
So basically, for our level, what we need to know, facial is the cortical
Nuclear if it is half side of the face with forehead sparing and it is above the level of pons.
Yeah, and we don't need to know like in the pons if it's getting affected the hypoglossal.
If it is at the pons, it would be half side of the face, which is.
Okay, thank you.
And also also, in terms of the sensory pathways, you should also remember that up to the level of, because all sensory from the face is going to the spinal trigeminal nucleus and tract. And this spinal trigeminal nucleus and tract is only going to cross above the level of pons. So if you have an injury to spinal trigeminal tract in pons or medulla, or nucleus is affected, ipsilateral side of the face would lose sensation.
Yes.
But above the pons, if spinal trigeminal lemniscus is affected in midbrain or in thalamus, contralateral side of half side of the face would lose sensation.
And this is what we discussed when we said the midbrain decussates for the corticobulbar as well. Remember?
Yeah.
But it's the same idea for the sensation. Let's carry on about the medial pontine syndrome or medial pontine structures. The most important that we have to know is the lateral rectus or the cranial nerve 6, right? And this someone already mentioned. The second thing that tells me that this is a medial structure or a medial lesion is a patient comes in with contralateral spastic paralysis because the corticospinal is
Affected.
and it's located
Medially.
medially. Okay. The second or other manifestations, the facial nerve, don't care about it now. Don't think about it. We'll use it as a lateral localizing mark or landmark, basically. Okay. Although, as I told you, sometimes it happens. It may be affected because it wraps around the abducens nerve. What other structures do we have medially in the bones? Medial lemniscus. So what would be the sign if it's affected?
Loss of
Loss of
vibration and
Vibration and proprioception where? Contralateral, because it decussates where? In the middle. And fine touch. What else? MLF. Excellent. So what would be the sign? Nystagmus in where?
In the okay eye.
In the not affected eye, in the okay eye. And the other eye اللي affected. What would be the sign?
It won't adduct.
It won't adduct. Yes, ipsilateral. What else? So we said corticospinal, we said MLF, we said medial lemniscus, we spoke about the abducens nerve. Is there anything else?
So the adducens nerves, it's going to go inward. That's one issue.
Right.
And then because of the MLF is also affected, so we're going to have basically twitching of the eye, or it's going to go back and forth. So that's two eyes are going to be messed up. And then we're going to have the contralateral spastic paralysis,
Yes.
corticospinal, and last but not least, we took the okay, yeah, the sensory. We were not going to be able, not sensory,
There's
fine
no sensory.
touch. We're
Yes.
not going to be able to have fine touch,
Excellent.
precaution, and
Vibration, fine touch, and proprioception.
proprioception.
Okay? So this is what we call.
Is, spine of the nerve.
Right. And since this is happening in the medial part of the bones, so what do we call it? Medial pontine syndrome. Is it common? In reality, it's rare. And I'll show you why. Because of the blood vessels. And I'll show you why. So, this is the medial pontine. What about this? This is the lateral pons. So can someone tell me what structures do we have on the lateral pons? Give me one.
Sympathetic.
Sympathetic chain. What will be the sign?
We're gonna have Horn syndrome.
Horner syndrome where?
In the lateral.
Ipsilateral. Horner syndrome, ipsilateral. So that's number one. And it is meiosis, anhydrosis,
and peptosis.
and ptosis. Excellent. So this is Horner syndrome. What other structures do we have? Vestibular nuclei. What's the function of the vestibulocochlear nerve? Balance and hearing. So what would the patient have?
He's gonna.
Vertigo and vertigo. It goes with the vertigo, dizziness, ataxia, and you said vestibulocochlear, right? So hearing loss. Can we turn off the other mic? Turn it off.
It's on.
Oh, it's off.
Yeah, it's on.
Okay. I have to hold it back. So, vestibulocochlear. Now, something that's important about the vestibulocochlear the nuclei of the vestibulocochlear nerve, they run both in the pons and the medulla. So the vertigo aspect is not that good in localizing, because still it can happen, and it happens very commonly in the pons and the medulla themselves. But what's more specific in terms of the vestibulocochlear nerve? Loss of hearing. So if loss of hearing is there, I know the cochlear part is affected. I know the cochlear part is located in pons only. But the vertigo aspect, it runs both in the pons and medulla. Does it make sense?
Yes.
So this is the vestibulocochlear. What else? Other structures?
I think the fifth also.
Yeah. Sensory nucleus.
Okay, so what will happen?
Loss of sensory thing in the
Pain,
entire face.
pain and temperature in
In the face.
where control
Ipsilateral.
ipsilateral loss of sensation in the face. What else? So we spoke about vestibulocochlear. We spoke about this sympathetic and the sensory. What else?
Facial.
Facial nerve. What will happen?
Ipsilateral loss of facial movement. Like
Exactly. Ipsilateral facial paralysis. What else?
all of it. صح and it's lower motor.
Yes, all of it. And I'll come to the why lower versus upper motor neuron. We'll touch base on it later on. Excellent. What else? So you only mentioned 4 things. I need more.
Did we talk about the spinothalamic?
No.
Spinothalamic, you did not mention it. No.
So are we gonna have
Spinothalamic
spinothalamic?
also
What will happen?
contralateral loss of temperature in the body.
In the body. Okay, so 5 things.
Spinocerebellar.
Spinocerebellar as well. What will happen? Ataxia.
So ataxia, spinothalamic, which is basically loss of contralateral pain and temperature sensation.
Yes.
And we're also going to have the cranial nerve affection. So حيكون عندنا facial paralysis ipsilateral.
Okay.
حيكون عندنا ataxia also, I guess.
Okay.
And we're also going to have other than facial, the trigeminal.
Remember the vestibular. Guys, try your best to apply a rule of 4 one by one. Remember first the cranial nerves, followed by the medial tracts, followed by the lateral tracts, and lastly is which cranial nerve is medial or lateral.
Okay.
And try to apply it. That's why I'm telling you, apply the rule of 4s. Go one by one. Don't mention one tract, then one nerve, then going back another tract and another nerve. Finish all the nerves, then finish all the tracts, and lastly, you'll be done. You'll get your diagnosis. So take it a systematic way. Okay? Does it make sense?
Yes.
Good. So these are the structures that are affected in the lateral pons. And can I give a name to such a syndrome? Lateral pons syndrome. Is it clear? So you only think from the name, you think about what structures that are in the pons in terms of cranial nerves, what structures that are lateral, and what tracts that are also lateral. Okay? Make sense? Good. Medulla. How do we recognize the medulla? Inferior olivary nucleus. And what's here?
Fourth ventricle.
That is open. صح?
Yes.
Good. Any questions عليها الميدولا? Look at the medial lemniscus. It's a line in the middle.
Yes.
Compare it to the pons. It was شوي. It's still in the middle, but it was like flailing, like a wings sort of thing. And what do we have above the medial lemniscus? MLF. Clear? More about the structures of the medial or the medulla. We have the pyramids. What do we have in the pyramids? Corticospinal. At this level, خلاص, we are in the lowest part of the medulla. There is no corticobulbar anymore, right?
Before the medulla, sorry. I know in the upper lateral pons, the superior cerebellar peduncle is affected.
Upper lateral pons, yes.
Superior cerebellar is affected.
Not superior cerebellar. the middle and inferior cerebellar peduncles. The superior cerebellar peduncle is up higher, it's related to the midbrain. But anyways, cerebellar peduncles are affected. So what's the sign?
Ataxia.
Ataxia.
But I remember the doctor saying in its superior, which is why I had a question about it because I don't know, maybe يعني لخبط
تمام. هذا الكويستشن
هذا
yes.
هو بس إيه.
It's the middle and inferior cerebellar
So
peduncles.
superior is only affected
Superior
in
صح,
the
it's
brain.
close, لكن it goes and relates to the midbrain. This is where the connection happens with the midbrain rather than the bones.
Okay, thank you.
Okay? No. Any questions? Good. Any questions? Are you still following?
Yes.
Okay. Any questions على الميدولا؟
Doctor, what's spinal tract?
ايه بس ما حكينا عن اللص في اللص اللي بيصير بالمدلل.
الحين حنيجي. الحين I'll come to it. So you asked about
What's spinal tract?
where it's in this picture?
In the middle.
It's extra.
Oh, this one.
No, next
Huh?
to the inferior.
Oh, this one.
Yeah, it's extrapyramidal.
I actually have no idea.
It
It's not
is, I'm
important. If you're sure about it, then yes. You know better than me, honestly.
Yeah.
You do, honestly, because this is يعني clinically insignificant, at least to me. I've never talked about it يعني.
حتى the doctor said it's not really relevant وإن the extrapyramidal tracts only like aid the pyramidal and like.
Yes, and when we speak about extrapyramidal tracts, we will be talking about extrapyramidal symptoms that happen with movement disorders or someone is taking a specific medication. They cause extrapyramidal tracts, extrapyramidal signs. But these, you'll take it more in the movement disorders. They're not important for now. In the brainstem, when we speak about يعني midterm, basically, you will not need it. Even in the final, no one is going to ask you about the tectospinal tract. No one is going to ask you. The same thing goes with the, where is it? I'll show you one. You see this one? Where is it? Wait. Rubrospinal tract.
Yes.
Do you know what's the rubrospinal tract?
Extra.
It's a useless tract that's not present in humans. Really, it's useless. It's only happens in like, I don't know, we call it submammals or something like that. يعني it's not important in humans. It's nothing, you know. فإحنا we're just showing you these pictures because it will make your life easier. طيب. Since now we're speaking about the medulla, can someone tell me what would happen if the medial part of the left medulla dies? The medial part of the left medulla dies. Give me signs and symptoms. Starting by you. Give me one structure. Sorry?
The hypoglossal.
Hypoglossal. It is located where?
In the middle.
In the middle. So it will be dying. There will be no effect, no function of hypoglossal on the left side. So what will happen to the tongue?
Deviates. Yeah, contralateral.
Deviates
Ipsilateral.
to the same side. Okay, if you see tongue deviation to the left, this is left medullary lesion. Okay?
كيف يعني deviate يعني؟
لما تقول له طلع لسانك راح يطلع بدل ما يطلع مستقيم راح يطلع زي كذا. Deviating to the left. Why is that? عشان الtongue جاي two muscles، واحدة من الرايت وواحدة من الليفت. And again, remember ايش اللي انا كنت دائما اقولها opposing factors. Normally they go like that. If one is dead, اللي هي right side is dead. Does that make sense?
Yes.
It's dead.
Yes.
It will override it. See, they're pushing against each other. دائما opposing factors. So if the right is dead, the left will be pushed وحيروح للright side. Make sense? Good. Yes.
It's ipsilateral because of the corticospinal.
Ipsilateral because this is the nerve itself. It's the nerve itself. We're already reaching the lower motor neurons. When I say this is the nerve, this is lower motor neuron, this is ipsilateral. It's not the corticobulbar tract anymore. No tract here. Make sense?
Yes.
طيب, you said hypoglossal nerve. What else will be affected?
The corticospine.
Corticospinal. What will happen?
Spastic paralysis to the
Contralateral spastic paralysis of the body. Excellent. What else?
Medial meniscus.
Medial lemniscus. What will happen?
Contralateral loss of vibration, proprioception, and touch.
Fine touch. Excellent. What else?
MNF.
MLF. What will happen?
Nystagmus in the OKI.
Exactly. And inability to adduct the affected eye. Okay? So, you see, we have the corticospinal tract is overlapping with the medial pontine. The MLF is also overlapping with the medial pontine. The medial meniscus is overlapping with the medial pontine. What's the only thing that tells me that this is the medulla?
The cranial.
Which cranial nerve?
12.
Hypoglossal. So the only thing that tells me this is the medial medulla is the affected tongue. Okay. What other name can I give this syndrome?
Medial medullary.
Medial medullary syndrome. Remember what I told you that we have, actually, I'll come to it. So this is the medial medullary syndrome. Let's say the same thing happened to the left medulla, left lateral medulla. The left lateral medulla, all of it died.
Yeah.
What would be the signs?
Okay, so we're gonna
Start by rule of 4.
Yes.
Yalla. Give me cranial nerves.
عندنا cranial nerve number 9,
9.
which is the
Nucleus
glossopharyngeal.
أعطيني النيرفز أسماء. 9.
Glossopharyngeal.
What else is
10.
affected?
10.
10, because it's also lateral medulla. What else? 11, because it's also lateral medulla. Excellent. Do we have other nerves that are in the lateral medulla? No. What about the tracts that are in the lateral medulla? Spinothalamic,
Sympathetic
spinocerebellar,
and sympathetic.
sympathetic,
sensory
and sensory trigeminal. Now look at it. Even though the trigeminal is in the pons, but it overlaps the pons and the medulla.
Does it affect the midbrain also ولا لا؟
No.
No.
Doctor, حتى vestibular.
Yes. حتى الvestibular overlaps the pons and the medulla. So if I see a vestibular lesion, someone with vertigo, the only thing that I can say if I want to localize someone with vertigo. Okay, guys, listen to this. This is important. Someone with vertigo. يعني I know إنه vestibular nucleus is affected. The only thing that I can say, ما بقدر أقول هي medulla ولا pons because it runs between them. لكن I know for a fact it's lateral lesion. Because the vestibular nuclei 100% it's not in the medial. صح?
Yes.
Yeah.
So the vestibular nuclei, the same with the sensation of the face, they run between the medulla and the pons. They're bad in localizing the area of the lesion. لكن they will help me know that it is lateral, not medial. I need to use the other cranial nerves to know where am I exactly in the pons ولا medulla.
Yes.
فهذا قلنا sympathetic, spinocerebellar. What else? Spinothalamic.
The inferior cerebellar.
اللي هي it goes with الataxia والvestibular vertigo. بس يلا, okay, we mentioned many structures الحين. Let's go to the cranial nerves. We said the glossopharyngeal. What will happen to the patient?
He will not be able to lift the palate.
Loss of taste is the posterior.
Loss of taste. Remember الفانكشنز الأربعة اللي تكلمنا عنهم في الcranial nerves.
إيه.
يلا, the first one, special sensation, loss of taste in the posterior 1/3.
Yeah.
Yes.
What else? Dysphagia because it's needed in the
Stylopharyngeal.
swallowing.
Yes.
صح? What else?
The parotid ichus.
Parotid, so salivary gland, he will have dry mouth.
Dry mouth.
What else? بس اللي dry mouth not that evident عشان we have still intact
Intact.
submandibular and sublingual.
Yes, which is stimulated by the patient.
7, yes. طيب, what else?
Loss of gag reflex.
Thank you. Loss of gag reflex, very important. And the gag reflex, you can do it in the midline or on the left side of the throat or the right side of the throat. You do it on the right side of the throat, he will gag. on the left side of the throat, he will not gag. Okay, or you will do it in the midline, and it will be weak. Okay, weak gag reflex. This is your important word, weak gag reflex. So this is the glossopharyngeal nerve. What else we have? Vagus. So what will happen? Vagus also helps with the swallowing, so it will add to the dysphagia. What else? Vocal cords. So something more important? Hoarseness. Excellent. What else? After that, we have the
11, which is
What?
the accessories.
What
You're
will
not
happen?
going to be able to shrug
Yes.
your...
And turning your eyes.
Exactly.
حتى
So
the soft palate will drop with the uvula will deviate بس ما أعرف which side.
so the vagus will cause the deviation of the uvula to the contralateral side because
What's
we
the-
have sorry
What's the...
لسان المزمار بتعرفها اللي فوق هذه بالحلق يعني
Okay.
اسمه لسان المزمار.
Okay.
Yes.
Since the 10th is affected, does that mean it will affect the heart rhythm?
This is a great question. The answer is no. Why? I don't know. Never seen it. Never read about it صراحة.
بس كمان مش
بس maybe يعني المفروض انها تسويها لكن I have no idea.
لأنه my cousin
We know الحين signs of our structures in the lateral medulla. We finished the cranial nerves, comes to the tracts. We spoke about which tract? Spinothalamic, what will happen?
Loss of contralateral pain and temperature.
Yes.
Excellent. Then
Spinocerebellar.
spinocerebellar, what will happen?
Vertigo.
Ataxia to the same side. Okay. Vertigo اللي هي with the vestibular nucleus. الفيرتيجو اللي هو حاسس انه الدنيا جالسه تدور فيه. Ataxia لما يمشي جالس يمشي مو متوازن. لكن هو بيقول لك الدنيا مو جالسه تدور. الفيرتيجو انه يصير يقول لك والله الدنيا جالسه تلف فيه.
Alright. So we talked about spinothalamic, so pain will...
Temperature contralateral.
Yes.
Spinocerebellar ataxia to the same side.
Yes.
بعدين ايش في كمان؟
في عنا vestibulocochlear.
تكلمنا عنه sympathetic Horner syndrome.
Ipsilateral.
Ipsilateral. Horner syndrome والspinocerebellar والspinothalamic كلهم are present كمان نفس الكلام بالبونز. لكن the only thing that I can take of it is إنه the region is lateral. Thank you. So, what's another name of this region that I just explained?
Lateral medullary or Wallenberg.
Lateral medullary syndrome. Excellent.
Doctor, is there any problem with the sensation of the face? The sensory part? It's also the
Yes,
lateral.
it's also affected, yes. It's also affected on the ipsilateral side. 100%, right. طيب. So we spoke about that. الحين vessels. I'm sorry احنا we're شوية يعني متأخرين.
عادي أنا بالنسبة لي I don't...
يعني hopefully it will be okay. See, every time we speak about the vessels, what they do إنه they separate them إنه الvessels بمكان وبعدين brainstem in another way. This approach is not good. You need to combine them both because once you know which vessel or where is it located, you will understand what does it supply exactly, and it will be easier for you to memorize. In fact, you will no longer need to memorize it. You can only draw the picture هذه وتحلوا المشاكل كلها. I'll just read here if I'm missing anything. Okay. Guys, help me with the drawing of the blood vessels.
Yes.
We have
Vertebral.
the internal carotid for now. I won't care about it. Why? Because it's anterior circulation. What I will care about is posterior circulation, starting with vertebral arteries. This is the vertebral column. Vertebral arteries coming here. Then
Basilar artery.
they join together to form the basilar. So these are the vertebral, and they become the basilar artery. Then and lastly they become the posterior cerebral artery. These are the main stem of the arteries, right?
Yes.
The vertebral arteries, both of them, they join to form the basilar superiorly, but again they send recurrent branches that they join together to form anterior spinal artery. I'm just drawing الحين الفيسلز وهذه الصورة نفسها we will take it نوصلها بالبرينستم. Okay? So what do we call this artery? Anterior spinal. Another thing about the vertebral arteries, what will they give? Two arteries that will rub here. Remember, they will rub. Remember my motion. What will they do? They will rub, they will hug. What are they going to hug? What are they going to hug? The brainstem. Okay, they will hug the brainstem. Remember that, I'll come back to it in a bit. So they're doing some hugging motion. The basilar artery, what would it do? The basilar artery will give some small arteries here, and lastly, or from here, from early in the beginning, it will give us another artery that will also hug. Okay? And the last thing here, we get the superior cerebellar artery. I don't care about the superior cerebellar artery, but remember it for your exam. After seeing this, and we have this is the posterior cerebral artery. After seeing this, we can apply the exact drawing we can take everything that we just explained and just paste it from here. We cut everything from here and put it over the midbrain. The end result would look like, not the midbrain, the brainstem. It would look like something like that. You have vertebral arteries. They join together and become in the middle. They are medial and they are supplying anterior spine, right, anterior part of the spinal cord, but before they supply the anterior spinal cord, they will supply medial side of the medulla. You see how they are in the groove of the medial medulla, in the rhomboid fossa? They will go in the middle and they will supply the medial part of the medulla. Now remember the hugging motion that I spoke about? It's all wrapping around the medulla and it will supply, we already supplied the medial medulla, now we are going to supply lateral medulla. We call this artery posterior inferior cerebellar artery. Then going up, they join together at the level of, what's this? Pons. So both vertebral arteries, they join together and they form basilar artery. And where is it located? In the middle, right? In the middle. So it will supply which part of the bones? Because it's in the middle, so it will supply medial bones, right? طيب. Here we have, what's this one called? Ica. It will do hugging motion and it will wrap around lateral bones. It will wrap around the bones, so it will be normally supplying the lateral bones. Does it make sense?
صراحة مخي سكر.
والله I'll draw it الحين مرة ثانية هنا حنسوي عندكم lateral view و anterior view. و last one, or قبل الأخير, this one, what do we call it? Superior cerebellar, and the last one is the posterior cerebral artery. Now, knowing that I have an anterior spinal artery which goes in the middle, right? So obviously it supplies something medial, right? And in this case it is medial medulla. If I cut the anterior spinal artery or صار له stroke, give me the structures that are affected since you said medial medulla.
The motor pathways like the corticospinal.
أعطيني إياهم الحين أنا أقول لك on the right side.
Like we will have left contralateral spastic paralysis.
Number one.
And also the medial lemniscus will be affected, contralateral. So on the left.
Left إيش? What will be
Left
lost?
body.
You
What
will
would be
lose
lost?
vibration, fine touch, and conscious proprioception.
Okay.
And
Start deviation towards the lateral.
Why?
Because the hypoglossal is cut on the side, so it just goes to this affected
To the
side.
affected side. That's right. And we have
MLF,
MLF. So what will happen?
nystagmus on
In
the
which eye?
unaffected eye,
In here.
the left eye.
Okay. And the other eye in here, right? What will happen to it?
It is affected. Yeah, it will be affected, so you would not be able to look medially.
Yes. It will no longer be able to adduct. It will no longer be able to look medial. What else? Yeah, I think that's it. So what do you call that?
Medial medullary spine.
So what's the artery that's affected?
The anterior spine.
You see? Because we draw it. And I suggest when you go to the exam, the first thing that you do, draw, make this drawing, honestly. Just draw everything. Remember, like, we have arteries that are in the middle and arteries that wrap around them. طيب? Does it make sense? طيب, let's say that I have a stroke in this artery here. I need
Doctor, what
someone.
about hypoglossal?
Sorry?
What about hypoglossal?
Yes, she mentioned it. The tongue will deviate to the right, to the side of the lesion. I have a stroke in this artery here. Name the artery and apply the rule of force. You will go. You will apply the. First of all, name the artery and apply rule of force systematically.
This is spike, right?
This is
Or is it the
this
other
one.
Oh, it's ICA.
This is ICA.
Yeah. So lateral bones.
Lateral bones is affected.
Yeah. So we're gonna have
Rule of force.
weakness of the facial muscles.
Which
facial
side?
expressions.
Which
Oh,
side?
it's right. So left. No, right.
Ipsilateral. That's number
We're
one.
gonna have loss of balance and
Okay.
balance and something else. Ipsilaterally.
Why would you lose balance?
Vestibulocochlear.
So what's the function of vestibulocochlear?
Balance.
And hearing.
Oh, yeah.
So he will lose
balance.
hearing as well.
And 7, 8, 5. Oh, trigeminal. We're gonna lose the sensation on the ipsilateral side of the face.
Excellent.
The 3.
So these are the cranial nerves.
Yeah.
طيب,
And
then
then we're gonna lose spinothalamic. We're gonna have loss of pain and temperature on the contralateral side of the
excellent.
and sympathetic
Okay.
on the contralateral side of the
Sympathetic is ipsilateral. Sympathetic is ipsilateral. What else?
spinal trigeminal, ipsilateral.
We said that already.
And there's
Spino,
spinal, cerebellar.
cerebellar. So what will happen?
Ataxia.
Ataxia. To which side?
Ipsilateral.
Ipsilateral side. Then what would you give a name for this syndrome?
Lateral pontine.
Excellent. Yeah, that's it. So if you take it step by step, the first thing you identify which artery is this, apply the rule of force. No longer needed to أجلس أحفظها بحفظ. خلاص, I can apply the rule of force for cranial nerves, for our medial, for spinal sensory tracts, and for motor tracts. These are medials, and the first one sensory are lateral. طيب, you will tell me what would happen if someone lost these small branches on the left.
Pontine arteries.
Okay, so what do they supply?
Medial pontine.
Okay,
So we would have.
so apply rule of force.
We would start with cranial nerve 6. So
Okay.
abducens. So we would have eyes down. No, just.
Both eyes?
No, it's
I told
Depends.
you.
Where is the lesion?
The region is in these small vessels here.
Okay, so right-sided. So we would have contralateral.
Help her.
it's in the
Ipsilateral. Okay, so ipsilateral what? Abducens nerve palsy. So which eye? هذه right sided صح? So which eye will look medially?
Right side.
The right eye will be medially deviated. That's the cranial nerve. What else?
And then that's it for the cranial nerves.
Okay.
So medial tracts. So the MLF.
جميل.
We would have nystagmus
جميل.
in the unaffected eye.
Nice.
And
Then
we would have
she will remember it now. So it's 4 motor tracts, all start with M, with an exception of one. It's a sensory
the
tract.
medial meniscus.
So what will happen?
We would have loss of proprioception, vibration, and fine touch.
And where is that? Ipsi or contra?
Contralateral.
Exactly. So that's medial meniscus. Then
And then we would have sympathetic, but ipsilaterally.
sympathetic is lateral.
Lateral, okay.
So this is medial. What do we have in the bones that's medial? A cortico spinal tract. So what will happen if the right corticospinal tract is affected?
Contralateral.
Yeah,
loss of
left-sided
temperature.
paralysis.
Yes, left-sided paralysis, contralateral upper motor neurons.
So
But-
left-sided spastic paralysis.
Yes, so what do you call this syndrome?
Medial pontine.
Exactly, medial pontine syndrome. طيب, medial pontine syndrome in reality is so rare because we have a big artery here and it's the one that's giving these small vessels, right? What commonly happens is the entire artery will be occluded.
And that's going to be fast.
So the entire medial aspect of the bones is dead. So both sides, right and left, medial pontine is dead. So give me now the clinical signs of the patient. What is expected?
Bilateral spastic paralysis.
Bilateral spastic paralysis, that's number one.
Both eyes.
Both eyes are looking medially.
You're gonna also have loss of spinal thalamic is gonna be not spinal thalamic. Medial meniscus is gonna be affected.
Medial meniscus is affected when?
Both.
Both. So he will have bilateral loss of proprioception,
Yes.
طيب, and vibration. Then
Also
MLF بالجهتين.
حتى facial.
What will happen?
the bilateral loss of facial.
Yes, bilateral of the facial. عشان هذه one of the cases اللي قلت لكم when the facial wraps around the abducens. فهنا احنا شلنا the entire artery فهنا the facial will be affected. فهي will have complete paralysis of the face, complete paralysis of the body, complete loss of sensation, the vibration and proprioception in the body, and
Doctor, why facial?
the facial wraps around the abducens nerve.
Uh,
What do you call this syndrome?
Locked in.
Locked in, and it's very scary because there is another structure that is affected. We call it
حتى like vocal cords, swallowing. صح؟
he can, the only thing he can do, two things. Move eye up and down. He will not be able to move it up and down because wait.
إلا vertical gaze is fine.
Vertical, yes, vertical gaze is fine. The only thing he will be able to do is two things: is breathe and move his eyes up and down. He will not be able to talk. He's not able to move. He's not able to feel.
Can they eat? No, صح؟
They can't. They cannot talk. They cannot do anything. The only thing they can do is breathe and move their eyes vertically.
Is this downward gaze possible?
No. Downward gaze palsy, he can no longer look down. Palsy means inability to do that. You know? So yeah, it's a very scary syndrome, and many patients sometimes they drown in their own saliva. Some of them they die out of the fear that they're going through, the stress that they're going through. Like they get because of how much stress they're going through, they get an MI and they die immediately. It's a very scary syndrome. But yeah, so it involves the entire basilar artery, which is the one that supplies the medial part of the bones on both sides. If we go higher up, the posterior cerebral artery, it's the one that supplies midbrain. And it sends, we call them the paramedian branches. These branches of the posterior cerebral artery, any one of those branches, they get occluded, we will start getting the midbrain syndromes. Is this clear?
Yes.
Is everything understood? Can you answer lateral pontine syndrome, medial pontine, locked-in syndrome, lateral medullary, medial medullary? Can you draw this picture? Let me draw it again.
Yeah, just one question.
Yes. Yeah. This is an anterior view of the brain and the brainstem. This is the brain. You go here. This is the anterior view. You're looking at it anteriorly. Okay? What do we have from here, from below?
Vertebral artery.
Vertebral artery coming in to make
Basilar artery.
basilar artery. Then, as it goes up, it will become posterior cerebral. Right? This is how they look. Exactly, this is how they look. The vertebral arteries, what are they going to do?
Spinal artery.
They were going to join in the middle and go down. This is what we call anterior spinal. Also, they will send some branch that will wrap around, and we call it
Inferior.
pica, and it will wrap around from behind, like, you know. This is which artery? Basilar artery. It will send artery that will go wrap around, and we call it ica, and it will send pontine. If I cut those pontines, it's medial pontine, only one side. If I cut the entire basilar,
The whole
locked-in syndrome. طيب. If I cut part of those branches that supply the midbrain here, from which artery is that? This one, which artery is this? Posterior cerebral. It sends some branches to supply the midbrain. If I cut those midbrain branches, we'll get one of three syndromes: Benedict, Weber, and Clyde. Make sense? Anterior spinal, if I cut it, what will happen? Medial medullary syndrome. This is the medulla in the middle, right? This is the bones in the middle. And here the midbrain, we have the branches. The pica, if I cut it and it's wrapping around the sides of the medulla, lateral medullary. I have ica wrapping around the sides of the bones, lateral pontine syndrome. Make sense? Can you identify the structures in each one of them? Any questions?
Doctor,
Yes.
when we were talking about the middle pontine, we said the tracts were MLF, medial meniscus, spinal, corticospinal, and
Corticovulvar, forget it. Don't think about it now.
okay, so
Don't
three.
think. Three. Technically three. And the abduce and sniff.
Yeah, that's
Right?
Yeah.
Make sense?
Thank you.
Any questions, guys? But let's take some questions here. Okay. We did that. Okay. Oh.
Is this question ولا
لا الحين في رسمة ثانية. sorry. شايفين هذا البوستيريور cerebral artery?
Yes.
If it wants تذكروا circle of Willis?
Yes.
You remember circle of Willis?
Yes.
So it will send an artery that will communicate with the anterior circulation. What do we call it?
Posterior communicating.
Posterior communicating artery. Posterior communicating artery is special because this is the level of what part of the brainstem is this? What part of the brainstem is this? Midbrain. What cranial nerves come from the midbrain? 3 and 4, right? So 3 is here. What happens, cranial nerve 3 will pass in close proximity before it goes up to the eye or whatever. It's actually straight to the eye. It will pass close proximity with the posterior communicating artery. So let's say I have a patient who has aneurysm at the posterior communicating artery. Here, he has an aneurysm, balloon dilatation of the vessel of the posterior communicating artery. What's the first structure that is affected?
Third cranial.
Third cranial nerve. What would the patient come in with the hospital?
Can't move their eyes.
What will happen? What will be? He will tell you, my eye
Down and out.
down and out. What about the pupil?
He won't be able to constrict it, so it's going to dilate.
So the eye will be dilated, the pupil will be dilated. Would he have any other signs about the strokes? No, because the only thing that's affected is the cranial nerve number 3. This is very important. If you see isolated cranial nerve number 3, it's one of two things. He either has posterior communicating artery aneurysm, and what should you do? Send him to neurosurgery immediately. This is an emergency, send him to neurosurgery.
What test
Oh.
do you use?
Sorry?
What test do you use?
Clinical physical examination.
بس
History and physical examination.
حتى محتاج المشي.
Physical examination, that's it. In neurosurgery, سوي consultation, you're waiting for the consultation, send them to CT. والله يجوا على طول, they will do the CT, maybe يسووها حتى جوا الOR. Okay? So, this is isolated cranial nerve palsy. طيب, in another scenario, ممكن يكون something more simple and it's more benign. The patient came in with sudden cranial nerve palsy. However, his pupils are spared. So the pupil, it can constrict, it works fine. Is this more dangerous or the benign, and why is that?
Benign, because
Why?
not all the nerve is affected.
Why?
Like on
What-
the side.
Aywa, what would be that cause? I'll show you now. Remember the functions تبعت الcranial nerve 3?
Yes.
What did we say about the function of cranial nerve 3? 4 functions. Do we have sensory? General sensory?
Yes.
When? Cranial nerve 3, does it have general sensory?
No.
No. طيب, does it have special sensory?
No.
No. Does it have motor?
Yes.
Yes. Where motor to ايش? Eye. طيب, does it have autonomics?
Yes.
Yes. And what would the autonomics do? Constrict the pupil. Nice. The fibers within the nerve itself. This is the cranial nerve number 3. This is the cranial nerve number 3. طيب? The fibers that are related to moving the eye, they are in the middle here. All of these are fibers to move the eye. However, the fibers that are superficial here, they are all the parasympathetic. So, if a patient has diabetes, remember, the nerve, within the nerve, there is a blood vessel running within the nerve to supply the nutrients to the entire nerve. صح? So what will happen to the blood supply? It will be feeding the entire nerve. If patient has diabetes, he will have something that we call arteriosclerosis, right? Remember, diabetes, one of the complications of diabetes is neuropathy. Why does the neuropathy happen? Because these small vessels that run within the nerves are getting occluded. So if I get the vessel here occluded, so the things are in the middle, here motor fibers are going to be affected. However, the things that are superficial are spared because usually we have some blood supply here. It will eventually feed the nerve. So in diabetes, the patient will have cranial nerve palsy, down and out, but the pupils are spared. Compare that to a posterior communicating artery aneurysm that compresses the most superficial aspect of the cranial nerve number 3, اللي هي parasympathetic fibers. They run superficially. Does it make sense?
Yes.
So if you see a blown pupil, a dilated pupil, this is more emergent and it's isolated, send him to neurosurgery immediately. Does it make sense?
Yes.
Any questions? Any questions? Okay. Now when it comes to cranial nerve number 5 and 7, remember they're useless in localizing in terms of medulla and pons. Why? Because they run in both of them. So a lateral medullary syndrome will cause facial sensation loss. It will cause dizziness and vertigo. The only thing that cranial nerve number 5 and 7 are useful in telling me that this lesion is lateral. Remember that. Cranial nerve number 9, we spoke about it when it comes to the dysphagia. Cranial nerve number 12, we spoke about it. It will deviate to the side of lesion. The only time it's deviating away from the side of lesion in the midbrain stroke, اللي هي يا Weber يا Benedict, and it will also, something to know that this is a midbrain stroke. Both will be on the contralateral side. Facial paralysis as well as body paralysis. In the bones and the medulla راح يكونوا different. Ipsilateral face, contralateral body. Make sense? Okay. Oh, this is a very important topic to discuss. Inshallah, it will be the last. I'm sorry, I know I keep saying the last, but you know, yeah. Facial nerve, as well as many other cranial nerves, they receive their fibers or their supply from both parts of the brain, right and left. Okay, but what we care about here is the facial nerve. Facial nerve is specific because the upper part is dual supply, that is the lower part is unilateral supply of the nerves. Does it make sense so far? Yes. Let's say that I cut the entire area here. Look, I cut the entire area here. What part of motor neurons am I cutting? Upper. These upper, they are on the right side, صح? Of the face, of the brain. So they are supplying which part of the face? Left side of the face. So if I cut them both, what will happen to the patient?
He will still have intact ankle.
Left ankle palsy.
Left?
Ankle palsy.
What ankle palsy?
Face ankle palsy. اللي هو يكون lower part of the face affected أكثر.
Because the upper part receiving dual supply, the upper part will be spared, but the lower part is receiving only one side, so this is the lower part is what's going to be affected, or the loss of function. Does it make sense? No, not really. طيب. The brain. Left brain supplies the right body. Right brain supplies the left body. صح?
Yes.
This is true.
Does this have to do with the gamma motor neurons and the alpha, or is it like something
No.
else?
No, forget that. هذا نسيه صراحة هذا المفروض ما تبي صراحة. So yeah, the cranial nerve palsies. the cranial nerves are شوية more advanced or more specific than the other nerves of the body. ليش؟ Because they receive nerve supply, innervation from both cortices, right and left. Cranial nerve number 7 is even more complex because it only receives dual supply for the upper area only. So if I lose the entire right brain, the upper area of the left face will still be innervated because it's supplied by the left brain. Okay? However, if I lose the right brain completely, I will lose the function of the lower face on the left. Why? Because the lower left face is only supplied by the right brain. Does it make sense now? And this is important for us because if I see a guy with sparing the forehead, with facial paralysis that's sparing the forehead, I know that this is upper motor neuron injury to the facial nerve or to the corticobulbar tract. I know that the lesion is midbrain or higher. Does it make sense? If it's in the pons, it will be a lower motor neuron injury. So I'm cutting the nerve from here when it's called the cranial nerve number 7, the lower motor neuron. The lower motor neuron is completely cut, so the entire face is cut. Make sense? Any questions? This is it. This is about it in terms of the facial. Okay. Oops. I don't think I put 12 cases. I had them, but we discussed most of them while talking. Okay. Who wants to read? يلا. You want to needle هذا? Okay. So read it and answer the question.
75-year-old male came to the ER with sudden onset left-sided weakness. He's able to speak coherently, move his eyes in all directions, and is showing all facial expressions. On tongue protrusion, his tongue deviates to the right and is unable to detect vibration. On his left side of the body. Localize the lesion using rule of 4. Like so.
You will do it. Completely do it systematically.
Okay. His facial expressions are there, so it's not pons. At least lateral pons. His tongue protrudes to the right side, so it's medial medulla. Left medial medulla, actually.
Left or right?
Left?
We don't.
Oh, right. Right,
why would you say right? So it deviates to the right?
Towards the lesions.
Another clue?
Unable to detect vibration on his left side, which is the
contralateral.
Medial meniscus.
Medial meniscus on which side?
Yeah, on the right side.
On the right side. So localize the lesion exactly.
Medial, left medial. Left medial. Right medial medulla.
Right medial medulla. طيب give me a name to this syndrome.
Left medullary. Left medial medullary. Right medial medullary.
Right medial medullary syndrome. Does it make sense?
Yes. Can I answer the second case?
Yes. يلا. Any question?
Doctor, why is it medial?
Because the hypoglossal, even though, it's the hypoglossal, and the medial meniscus is in the middle, right? What other signs? Okay, this question is for you. What other symptoms would the patient have?
In the middle?
What other symptoms do you expect the patient is going to have?
Alright, so it's middle medullary, and we
use the rule of 4 to expect other signs the symptom may have, the patient may have.
Yeah. Okay. So we're gonna also have problems with the. So since it's in the middle, so we're gonna have also spastic paralysis supposedly.
Where?
In the contralateral, which is on the right side.
Excellent.
And not only that, but we also should have. I don't think we have corticospinal. Not corticospinal. I mean bulbar. Yeah, we don't need it. So other than that, we're not gonna have vibration, which is medial meniscus.
We said that.
We said the corticospinal also. We said that. Okay, and he said MLF, which is.
So, right INO. Right
So
eye.
his eye is gonna start twitching.
The left eye nystagmus, the right eye cannot look medially. طيب.
Alright, can I do the LASIK?
Yeah, sure. Please.
Because
regarding the right eye and neuro, the doctor said something about the MLF, something that he wanted you to mention.
He's trying to okay, explaining هذه الconjugate gaze. Whenever I have both my eyes are looking straight, okay? If I want to look left, one eye will look left and the abduct, and the other eye will adduct. صح? Makes sense? In order for me to do it together, I need 3 things. MLF for the right eye to adduct, PPRF for the left eye to abduct, and the third thing, PPRF is called the paramedian pontine reticular formation. Paramedian pontine reticular formation. It's needed for the lateral gaze. One eye is using PPRF, the other eye is using MLF, and both of them are using cranial nerve number 6 على left one عشان it's abduction, and the second one is using the cranial nerve number 3. I need all these 3 components: cranial nerves, PPRF, and MLF. If PPRF is lost on the left side, he will lose the lateral gaze. Now the pathway is more complex. I honestly did not revise it, but in general, this is the idea. One is using PPRF, the other is using MLF, and both are using cranial nerve number 6 and cranial nerve number 3. PPRF and MLF is what connects the cranial nerves, and there is one specific nucleus that we call it nucleus of Eden.
Westfall, right?
What is it? Edenfall or West?
And it's where Westfall.
Yes, this one, this nucleus. It's the area where all of them connect together. You know, this is what we use for it. Honestly, I can revise it in 5 minutes وارجع اعطيكم اياها بس.
It's okay.
It's not that important. At least
Thank
you
you.
can step 1 level.
Is what she said with us, is the thing she said with us, or it's not?
I don't think it's included in the I don't think it's included in your midterm. عشان vision is still not included, صح? Is vision included? Good. Who wants to read?
I'll do it if you want. A 34-year-old female, 3 months later, hearing loss and ringing, no ear infections, or cold, whatever the sex is, doesn't use ear swab, ears are normal and on PEX.
Physical exam.
Okay, physical examinations. Neuro exam shows left-sided facial drop and numbness and diminished corneal reflex. An MRI confirms a mass located at above the cellular diaphragm, adjacent at sagittal sinus, between cerebellum and lateral pons, dorsal midbrain and lateral medulla. So, can we start with the rule of force? For starters, we're going to talk about how she has a hearing loss and ringing.
So what's the thing in there?
That's the vestibulocochlear, which is going to be the 8th cranial nerve.
And where is it located?
It's lateral pons.
Okay.
And
can I say for sure that this is lateral pons?
Yeah,
because it's
Because
hearing,
it's hearing loss. If I don't mention hearing loss, then I only know that it's lateral.
Lateral.
But if I say hearing loss, I know for a fact this is lateral.
Pons. Oh yeah, because we also have it in medulla, not medulla, midpoint, midbrain. Medulla, right?
Like hearing loss is specific for pons.
Yes. Okay. So it's lateral pons.
Okay.
Okay, that's the reason one of this, and he's having left facial drop, which is also cranial nerve number 7.
Which located?
Which is located laterally also.
Lateral ايش?
Ipsilateral.
Lateral, which side? Which lateral midbrain, lateral pons?
Lateral pons.
Lateral pons as well. So I have two clues
reasons
that are telling me this is lateral
pons.
pons.
Cranial nerve number 7 and cranial nerve number 8. And he's having numbness and diminished corneal reflex.
Corneal reflex, what's the axis of the corneal reflex? You will tell us. Give me the afferent and efferent. Corneal reflex, I'll just explain it. Sure, I'll explain the corneal reflex and you will tell me the axes of the corneal reflex. I bring a cotton ball. I touch the white part of the patient's eye and he closed his eye. This is an intact corneal reflex. Based on my description, give me what sensed the cotton ball and what caused my eye to close.
Trigeminal.
What sensed the cotton ball?
Trigeminal.
Which part of trigeminal?
Sense.
Ophthalmic.
Ophthalmic, yes.
Which nerve
facial.
caused my eye to close?
Facial. Yeah.
Facial.
Yes.
This is normal corneal reflex. In this case, he's saying diminished corneal reflex. So what does that mean?
Facial is affected and the sensation, which is the trigeminal, is also going to be affected.
How is the trigeminal affected? Why is it affected, I mean?
Trigeminal might not be affected because it's afferent.
It's fine. So it's which part of the bones is it? Lateral bones. صح?
I remember someone told us the sensory, we cannot tell if trigeminal is affected or not, since facial is carrying the efferent.
Afferent is with the trigeminal. Efferent is with the facial. Any failure of sensing or response will lead to diminished response.
So how do we know it's
بس
either one?
بس look, if the complete sensation is gone, like جيت قصيت الترايجيمينال مقص يعني 100% lost, this will cause the eye not to close because I'm not sensing it in the first place. However, in terms of stroke, the stroke is something that's progressive. بالبداية 10% من النيورونز ماتوا ففي weakness بعدين 20%. As time progresses, more neurons are dying, more diminished reflex. But even if I can sense like 20% sensation, my facial nerve is intact. My facial nerve will contract to any small stimulus. This is what they mean. But in general, I'm giving you the extreme عشان تفهموها. I kept the trigeminal nerve. Stroke يعني 100% ده. يعني حتكون diminished corneal reflex. لكن in general كلامك صح. The main effect, the main خلينا نقول precursor to closing the eye أو الرeflex نفسها is the facial. And in this case the facial is affected as well because it's located where? Lateral bones. And the trigeminal is also located where? Lateral bones. So what would you answer here?
It's cerebral lateral.
What do you call this syndrome?
Lateral pontine.
Lateral pontine. Lateral pontine. But if I want to be specific, give me a diagnosis. I said here there is an MRI confirms the mass.
Tumor.
What type of tumor? What's the tumor that can cause this? What tumor can mimic lateral pontine syndrome?
Is it the schwannoma?
Schwannoma, vestibular neuroma, schwannoma, acoustic neuroma, multiple names. Okay?
Yeah, that's
Schwannoma at the cerebropontine angle. Make sense?
Is this what you mentioned? This was which lecture is this mentioned?
These are the tumors لكن يعني in general tumor الشوانوما if it's big enough it can mimic lateral pontine syndrome.
The pineal gland.
Okay.
Doesn't
Pineal
that
gland.
tumor affect the, since it's like lateral? No.
بس البينيال gland where is it located? At which level? Posterior ايش؟ Move on. Posterior midbrain. Posterior midbrain and it's high up. It's only like كان زي هيك جالسة on the posterior aspect of the midbrain. If it grows up, superior colliculus is affected, vertical gaze palsy. Yep.
Doctor, what was the angle you were talking about?
Cerebropontine angle. Cerebellopontine angle. Cerebellopontine angle. Acoustic neuroma or a schwannoma or acoustic neuroma. Multiple names. Yeah, these are the names. Like, if I may ask you now, what other symptoms would the patient have give me one symptom that the patient would have, or actually two.
So since it's lateral, it should be sympathetic also.
So since it's lateral, it should also have sympathetic, I guess.
So what would happen to the patient?
Hoarseness. More hoarseness? Horner syndrome. Horner syndrome, my bad.
So what will happen with the
so he's gonna have like ptosis and meiosis and hydrosis also.
And hydrosis.
Hydrosis. And not only
on
that.
Which side? Which side?
On the ipsilateral.
Excellent.
And not only that, because we also have a problem with the spinothalamic also.
Okay.
So that's gonna be also lateral, contralateral. You're gonna not be able to have pain and temperature.
Excellent.
Yes.
So anyone would add anything?
Unicerebellar
Okay.
ataxia.
Ataxia on the same side.
Yes.
Anyone wants to add anything?
But didn't we say that spinal with
midbrain. Anyone would add anything?
Sympathetic tract.
Not abducens. Sorry?
Sympathetic tract.
We said that, but we have also the sensation of the
Oh yeah, the face.
The face.
Sensory nucleus
It's also in the
spine.
pons. He would lose the sensation ipsilaterally in the face.
طب الحين إذا it's a lateral lesion in whatever part of the midbrain, it's going to cause loss of sensation.
Midbrain?
Not the midbrain, the brainstem.
Yes. The pons and medulla, yes. المidbrain شوية تختلف.
Okay.
Yes.
Okay, thank you.
No worries. واجين ممكن بعض المرات remember تبعت البونز والمدلة they overlap كثير. فأنت your job is to find the stuff that are specific to the bones مثل hearing loss, stuff that are specific to the medial bones, lateral rectus, stuff that are specific to the lateral medulla, dysphagia. فأنت بس بدك تاخذ الكلوز الأشياء اللي specific اللي تقول لك this is lateral medulla or this is medial bones.
So
this
lateral
is what
medulla is dysphagia.
Yes.
And lateral medial.
Medial medulla is something specific to medial medulla.
Is the hypoglossal.
Hypoglossal. Something
بس
specific.
حتى لما يكون
Forget it. اعتبريها مو موجودة.
لأنه ما.
انسوا corticobulbar palsy. Forget it. ولا السودوبالبر forget it. بس هذه بالميد برين. صح ليش؟ عشان الميد برين is specific فيه both the face and the right side both are contralateral. Other than that, one is ipsi, the other is contra. طيب? Does it make sense?
Yes.
Any questions? Let me see if I covered everything. طيب, who wants to do the third one? You'll do it. Yeah.
Okay, a 59-year-old male comes complaining.
Oh,
of
you have the lecture. سرقتوها.
So he has diplopia and drooping of the right eyelid. Physical examination shows dilated right pupil that is non-reactive. While the patient is looking straight, the right eye is directed lateral and inferior. MRI will most likely reveal an aneurysm involving which artery?
So answer that.
Posterior communicating.
Posterior communicating. It was her question.
I'm sorry. Sorry.
She's mad. طيب.
So the accommodation reflex فيها مشكلة.
Okay.
So it's either the optic nerve or the oculomotor.
Okay.
And
بس
then they
لا,
said-
it's not the accommodation that's اللي فيها مشكلة. Look at the neurological deficit that he has. The eye is located where? Where is the eye located?
It's lateral and inferior.
Down and out.
Yeah.
So immediately
so
you
it's
know.
oculomotor.
Immediately
Yeah.
you know that. حلو كملي.
Yeah. So the artery we said posterior communicating, and the
What
muscle.
to do next? The best next step in management?
Neurosurgery.
Call neurosurgery.
Yeah.
Send him to CT while waiting to neurosurgery or على طول they will do it بالORs. يلا.
Yeah, and the muscle that will remain functional is the lateral rectus, because it's the only one that's supplied by the sixth cranial nerve.
طيب, if I added superior oblique.
It will also remain functional because it's supplied by the trochlea.
Excellent. Any questions?
Doctor, yeah, how do we explain this case again?
I'll come to it. حشوفها الحين السؤال بس. One second, go.
What's the cause of diplopia?
Diplopia, because whenever, okay, so if both my eyes are looking straight, I see only one object, right? If one is looking straight and the other is that, so I'll be seeing two. I'll be seeing you and I'll be seeing him, and they will be not organized, the both eyes, so I'll be seeing two. That's so any cranial nerve 3, 4 or 6, they can lead to diplopia. Okay? The only thing that's specific to trochlear nerve 4, it will be a positional diplopia. Because if trochlear nerve is out, one eye will be straight and the other will be up. So what would the patient do to fix the diplopia?
Move the head.
They will do like this. They will be walking like that. And they will be seeing normally. They won't see two. The moment that I fix their face, they will be seeing two. They will get dizzy. And it's all down the head. Clear? So, now in terms of your question, the patient has diplopia, he's seeing two. And he has ptosis of the right eyelid. Right? Right eyelid, yes. So whenever I see ptosis, there is one of two causes. Or three causes, let's say.
Horner syndrome.
Horner syndrome, myasthenia gravis,
or oculomotor.
Damage to the
or oculomotor. صح? One of three things. Myasthenia gravis, we're not talking about it, we're talking about brainstem. So again, it's only one of two things really. يا Horner syndrome, يا oculomotor. Immediately, من one word, I know what I'm thinking about.
Aneurysm.
يا انه الاوكيلوموتر or Horner syndrome. I need to read more to know which one is happening. Physical exam told me that there is dilated pupil. Horner syndrome, does it come with dilated pupil?
No.
What's the sign of Horner syndrome?
Meiosis.
Meiosis, anhydrosis, ptosis.
And in this case, I don't have anhydrosis, they did not mention it, and at the same time I have dilated pupil. So I know for a fact what I'm dealing with is oculomotor, because I ruled out sympathetic. Now I will carry on with the question. While the patient is looking straight, the right eye is down and out. So this again tells me that this is oculomotor. MRI will most likely reveal an aneurysm. Well, how did we come up to the conclusion that this is an aneurysm?
Only oculomotor.
Why? Why are we saying this is an aneurysm?
Because it only involves the functions of the oculomotor.
So it's isolated oculomotor. This raises the suspicion, and what also raises the suspicion even more? The fact that it's dilated pupil. Why? Because this is the cranial nerve. This is the cranial nerve. The superficial fibers are all parasympathetic. They are the first affected in an aneurysm. بالعكس, حتى sometimes the aneurysm is small enough to only compress the fibers, the parasympathetic fibers. So a patient would come to the hospital with unequal pupils, one dilated and the other is normal, you know, without the out and down and out that we always talk about.
How the Horner?
Sorry, no, it's dilated. Horner is never dilated. Okay, he will come only with one dilated. You know what would happen? What would be confusing? You will think that he has Horner in the normal eye, because one is big and the other is abnormal. Lakin, this is advanced. Think about it. Take an extreme case, down and out with dilated pupil. Make sense? Now خلصنا.